All right. Okay. Good morning, honorable members, and good morning, our staff and some of the other leaders in the country have logged in. We are in a portfolio committee of health, and we have a meeting that is just starting now. May I just, as a reminder to honorable members, read the following, that we welcome you as you are logging into this virtual platform. As before we proceed, it would be important that I remind you all that the virtual meeting is deemed to be in a precinct of Parliament and therefore constitutes a meeting committee of a National Assembly for official purposes only. In addition, the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same power and privileges that apply in a sitting of a National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said in the House and may be ruled upon. All members who have logged in shall be considered to be present, and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of the other members. When recognized to speak, please unmute your microphone and then connect your video, as some of our sittings are live and therefore we'll need to see who is speaking. Members may make use of icons on the bar at the bottom of their screens, which is an option that allows a member to put up his or her hand, raise a point of order. The secretary will also assist me in alerting the chairperson to the members who are requesting to speak. When using the virtual system, members are urged to refrain from or desist from unnecessary point of order or interjections. We shall now proceed with the business of the day. May I recognize Umbali, our support staff, who is acting for Ms. Malamba, who is just delayed to deal with the housekeeping at school of a child, to actually hate members who are present and any apologies if there are.
Good morning, Chairperson and the members. Present in the meeting is Dr. Jomo, Mr. Munyai, Ms. Gela, Mr. Sokacha, Dr. Jacobs, Ms. Wilson, Ms. Ishmael, Dr. Tembewayo, Ms. Shira, and Mr. Van Staden. I haven't received any apologies.
Okay. Honorable members, in the course of the week, I received an invitation, which I'm just trying to look up to read to you, but maybe I may paraphrase it. This invitation was coming in from the chairperson of the Portfolio Committee of Trade and Industry, and it would be better that I read to you. It was actually coinciding with today's meeting. They are discussing something which is quite important in that Portfolio Committee today, but I since then apologize on your behalf now that we are in this meeting. The letter was actually inviting us, let me read it. The joint meeting addressed to me on the 27th of May, the joint meeting with the Portfolio Committee on Trade, Industry and Competition on World Trade Organization temporary waiver for the COVID-19 vaccines. The Department of Trade and Industry will be holding a meeting. Okay, the Department of Trade, Industry and Competition will be holding a meeting. The meeting has been scheduled for 9 o'clock on Tuesday, the 1st of June. The meeting will take place on Zoom. Please confirm attendance by Friday, which was the next day. So we then declined this invitation, signed by Dean Kosi, Member of Parliament, Chairperson of the Portfolio Committee on Trade, Industry and Competition. We checked with the administration and they felt that we are also dealing with something quite important that we can't shift. What is going to be discussed there probably is also very important, but we already have scheduled the meeting and we are dealing with issues that are also the main focus of this portfolio committee. Hence, I declined that invitation on your behalf. So we are here now to continue with our work. And may I then check with the leadership of, I think, can you flight the agenda for today, Ms. Mbali? Khayelitsha Forum, I think. We would shortly start with the first presenters. I hope they're logged in. Whoever has joined us from this presentation that will be made by Khayelitsha Health Forum and Klipfontein Health Forum, hopefully they will be making a combined presentation to like two entities, one presentation. We would actually allow you to introduce the delegation that is here. You only have about 45 minutes to make your presentation. The members will then discuss with you. We do have a day to really engage other institutions, so we will try our best to stick to the time. If I may then recognize the presenters of Khayelitsha Health Forum and Klipfontein Health Forum, and then they will start their presentations after their introductions. Thank you. I would imagine those leaders came in a bit earlier to just check with our staff how to unmute and mute themselves and how to switch on their videos and talk. This pause was allowing them to move to go on to presentation. One of them can start. Ms. Mbali, do we have the presenters who are logged in from these organizations?
Sorry, Chair, we're still checking. Sorry, thanks.
We are still doing what?
We're still checking if the presenters are here. Thank you.
Sorry, Chair, I was speaking to Vyokas now. She said she sent the link to the Khayelitsha Forum yesterday. So they are supposed to be here in the meeting.
Do we know, or do you have a number of one person there? Is there anyone from Khayelitsha Health Forum who has logged into this platform? Dr. Kutsie, good morning. Are you ready to give us your presentation, or you just attending to see how things go? We can put you front. You are the last to present for the day, but I see you are logged in now.
Dr. Dlomo, yes, I'm actually just want to see how it goes. Unfortunately, I cannot present currently. I still have booked patients till 10 o'clock, so it would be a problem for me to do it now. But after 10, I can present.
Okay, all right. Okay. Thanks, Dr. Kutsie. Ms. Lindokuhle, can you flight the agenda again and see who is here, who also is like Dr. Kutsie, who has come in a bit early but not ready to present? Let me see. if anyone has got a number, let me just, okay, there's a presentation. The Children's Institute, University of Cape Town. Anybody from that institution here? Anybody from the Children's Institute, University of Cape Town?
Mr. Chair, Mr. Dlomo, this is Professor Saluji. I'm one of the presenters and I am around.
Are you ready or want to wait for your leaders, Professor Saluji?
So I've got a 15-minute slot and I'm happy if it saves the committee some time to proceed with my presentation. I'm not the chair of that committee. The rest of the members haven't joined, but if it assists the committee, I'm happy to do my presentation.
Let's do it this way, Professor Saluji. Let's give you 3 minutes to phone the other members, send them your login and tell them to log in so long. After 3 minutes, we'll start with you. They will then add on. They will find us at least with something going on. So let's give you a short break to then just check with them, indicate that we are starting with them.
I'll certainly do that, Dr. Dlomo. I'll try and contact them immediately. Thanks.
Okay. All members, grab your cup of coffee, 3 minutes break, then we are back starting with the Children's Institute of University of Cape Town. Thanks. Okay, honorable members, let us therefore start. We are back here. I've just been informed by Ms. Mbali that the Khayelitsha Health Forum will be logging in shortly. However, they will have to wait until we complete with the ones that have already asked. I'm sorry to do this to you, Professor Saluji, but the people who owe you more apologies are those who were given their slot and didn't use them at the right time. You can now.
Thanks, Dr. Dlomo. Unfortunately, the other two members of our team I haven't been able to contact. So do you want me to proceed just with my 15-minute piece?
Sorry, Professor Aluchi, I just got disconnected a short bit. You can now start introducing yourself and those who are with you, and then your presentation. You've got 45 minutes to present to the portfolio committee. Thank you.
So, Dr. Dlomo, unfortunately, we were a 3-member team, and the other 2 members of the team I haven't been able to get hold of because we were anticipating starting at 10 o'clock. So I'm afraid that hasn't been successful. Over.
Yeah. Is that putting you at a disadvantage if you are proceeding alone? You probably need to wait for them, you suppose. I think so. Is that what you
I'm
wish?
afraid I'm a small part of the overall presentation, and so it would be a disadvantage to the team. So I'm afraid, I mean, I can do my own bit in isolation if it saves the committee some time, but I'm afraid I can't, I'm a small component of the team.
Okay. Khayelitsha Health Forum, you have taken 10 minutes of your time waiting for you. We were waiting for you. You can then start on your 45 minutes. We have taken 10 minutes of that allocated to you. You can introduce yourself, start your presentation. Thank you. Anissa, is that not what I was told? The name is Anissa.
It's Tamara Sam, Chairperson. I don't see her on the platform though.
Okay, you spoke to her a short while, then she said she would be logging in.
She had logged in a minute ago.
Yeah, tell her that we are waiting for her. Yeah, I'm sorry, honorable members. This was confirmed yesterday and they were aware they are starting at 9. And what has happened now, nobody has an indication, but we'll wait so long because it is not fair to get Professor Saluji to do this. He has just indicated. Ms. Mbali, please, or Linda Wuhle, please get the presenters to come in, please.
We're working on it, Chair. Thank you.
Yes, Professor Saluji.
Dr. Dlomo, if it assists the committee, since you seem to be wasting your time, I'm happy to present my bit in isolation. I'll probably take about 10 to 15 minutes, and then the rest of the team, if it helps, can present when our time is scheduled.
No, we will be disjointed in that regard. We could allow you to present now. If you are saying, hold on, if you are saying, while you are finishing your presentation, they will log in now, we'll end up having so many scattered presentations from the Children's Institute. They are saying to you, they will only come in at the right slot, not now.
Unfortunately, I wasn't able to contact the other members, but that's fine. Thank you very much, Dr. Dlomo. I'll join the rest of my team.
Yeah. Yeah, honorable members, may I request that you remain logged in and do not disconnect. We are talking to the Khayelitsha Health Forum, and they are saying they have a connectivity problem, and Ms. Machalamba is taking them through that part. And so I would not be able to indicate how long it will take, but they have been made aware that this is their slot and their time, and therefore, if they do make it, it's fine. If they cannot make it, it will not be possible to reschedule to another slot because this is the space that was allocated to them. So we would ask you to remain logged in, and we will make a call when we're about to start. I'll probably post it on the group. I will ask Ms. Majamba to post it to say, please, we are now about to start, and then we'll come back to this platform. Thank you. Yes, can I check if Mr. or Miss Dibongo has logged in? One of the members from Khayelitsha Health Forum, I'm told, has logged in, but then we need to get them to indicate, yes, it is true. Who has logged in from that forum?
Hello.
Please indicate who you are.
Hello. Can you hear me?
Please go on and tell us who you are.
Hi, good morning. Apologies. We only get connected now. We're denied there's no network around here. My name is Mzanyo Dibongo. I'm from the Khayelitsha Health Forum.
Okay, Mr. Zanya, please go on. You had 45 minutes from 9:05. Now you don't have that time from 9:05. You have the remaining time from that time slot. So take us through your presentation and introduce those who are with you here.
Thank you, Chairperson. Apologies again for being late. There was a problem with the connection. I'm here with Mr. Petros Mato. He is a Deputy Chairperson of the Cultural Forum, and Thandi. She's also a member of the executive of the Cultural Forum. In principle, there is a support for the purpose of the NHI bill that seeks to achieve universal access to quality healthcare. There has been a lack of public participation with the communities most affected and impacted by the NHI. Clarity is required on how people with disabilities and special needs will be accommodated in the NHI bill. To what extent has the stakeholders engagement process targeted disability sector and other marginalized groups, for example, children, women, and the aged? Government indicates that it embarked on a public participation process on the NHI green paper and white paper phase before the NHI bill was tabled in Parliament. In terms of Parliament oversight function, did government provide Parliament with a stakeholder engagement report? That is the question. If so, then stakeholder engagement report must be made public to verify the extent and reach of the public participation process at the level of the executive government. Submissions were also made during the green paper and white paper stages of the draft bill. Did the government account to Parliament about the extent to which those submissions were taken into account in the formulation of the NHI bill that was tabled in Parliament? And did the executive give feedback to those stakeholders who made submission? If communities are excluded from consultation and involvement in the NHI, then the NHI will not happen, because the NHI is about the healthcare needs of the poor communities, who should have a major say in this key piece of draft legislation that affects all South Africans, and especially the poor. Khayelitsha and Klipfontein Health Committees also urge that public participation process on the NHI bill be protected from political interference and party political squabbles and point scoring. Provinces, district, and local municipality also need to work hand in hand with healthcare facilities to provide better service. Currently, there is a culture of blame, shifting, and lack of responsibilities. The one structure will blame the other for poor service delivery, or the one structure will say it is the other structure responsibility. In the end, service delivery suffers, and the recipients of the services are shortchanged. There has been no feedback to stakeholders and interest parties about the success and failure of the pilot project. This feedback needs to happen to allow communities the opportunity to use the lessons learned in order to move to a better point of achieving universal access to healthcare for all. Clarity is needed with respect to how the NHI bill will address the transition between private and medical aid and universal care system for all. The gap between the private and public healthcare needs to bridged, and how this is done is important. Health committees are statutory structure created by the National Health Act. The health committees are community-led and drawn organizations which act as a bridge between the facility and the community and act as a vehicle for community participation in their own health. They are critical structures which exist in the primary healthcare system to support and strengthen the health system and act as a vehicle for community participation. However, the role and function of health committees suffer because they are left to provincial legislation. Health committees as statutory structure have not been factored into the NHI bill. Health committees are not funded, but play an important role in communities at a very local level. Health committees also have a role to play in ensuring that health facilities and staff became accountable to the quality of service delivered. Nurses and doctors need to be trained on inclusive approach to service delivery and to work in partnership with community structures and health committees. The role, functions, and authority of the district management offices needs to be clearly spelled out, as well as its role in relation to contracting unity for primary healthcare. There needs to be clarified around all the structures and research in the NHI and how they relate, support, and complement each other. If this is not captured and clearly defined in legislation, we will find ourselves with conflict and competition between structures. Minister of Health appoints the board. Provision must be made in the legislation for civil society representation in the NHI board and all other structures and research in the NHI. This will help to build the required checks and balances to hold government accountable to the people. It will build the principle of transparency and accountability that our democracy needs. It will also help to tackle the corruption scandals that government and other organs of states have been lodged with. Accountability mechanism of the NHI must be clearly spelled out in the NHI to ensure that government is accountable to the people and to deal with corruption and potential failure of the NHI. Clarity is needed about exact details and working of how money is going to be pulled to fund the NHI. A proper analysis is needed of whether South Africa is in a financial position to fund the NHI, and whether there is sufficient trust by the public that government will be able to deliver an NHI that is inclusive of community participation in all phases. The NHI's bill needs to spell out very clearly that monitoring and evaluation mechanisms are going to be used to monitor the NHI fund. Monitoring and evaluation mechanism and process must include representation of civil society for transparency and accountability. Transparency is also needed when it comes to tenders and employment opportunities. We need to ensure that government officials do not get kickbacks and benefits from the NHI fund. Guarantees are required that the NHI fund will not be subjected to state capture and looting. We need to build confidence in government, and this must be done by partnering with civil society in a manner where they can influence, have joint control, and jointly own the purpose and outcomes of the NHI fund. An electronic system is required that will store information of patients that can be accessed throughout the country. It needs to be a national system that will enable patients to access services anywhere in the country. Recommendations. It is recommended that government and parliament provide a report of the nature and extent of its public participation process on the NHI bill in the form of a stakeholder engagement report and stakeholder analysis report. It is further recommended that this report made public. Should this analysis indicate that the public participation process was lacking, then the public participation process needs to be extended to allow true consultation with communities and especially marginalized groups in our society. It is recommended that government and parliament abides by a non-partisan and unbiased approach to public participation on the NHI bill. Further recommendations is that the evaluation report of the NHI pilot project be shared with communities and stakeholders, and that the monitoring and evaluation tools and processes used to evaluate the NHI pilot project also be shared, made public. Those submissions are acknowledged, and that feedback is given to organization and individual about how specific content of submission shaped the NHI bill. The government and parliament work closely together with community-based structures in the rollout of public participation process from the conceptual stage, and that communities are not reduced to mere recipient of information from a top-down approach. I thank you, Chair.
Okay. Yeah. Okay. Mr. Mzwama, I don't know where to start with your submission, but let me just say this to you. We are the 6th parliament currently. If you probably would want to know the NHI document and the green paper, white paper, I would advise you to go to the archives of the department, because we are not at that level now. That level was probably a long time ago. Number two, some of the issues that you are raising, one would advise you to find space to the Department of Health to raise with them, because there are also issues that are in the public domain that probably may help you to answer. We would like to listen to your presentation and incorporate it into a discussion that this portfolio committee will have within itself in finalizing this process. I don't know now, when you are saying in recommendation, you need to get to know. We are at the right time. We will give you an indication that we went into 36 meetings as this portfolio committee that were attended by not less than 500, some of them, in various parts of the country. We did not do all wards and all areas, but there are some that will be, after this, be done by the NCOP. That report will be made available at the right time. So we would also be saying, if there is, we were particularly also in Khayelitsha. We came to Khayelitsha, and the meetings were well advertised in advance with municipalities supporting us. So some of these logistical issues that are contained in your presentation are things that you can refer to. They are available and they are there to give competence to it. But so we are here listening to a submission. We are not here largely. I'm just being very fair to you to answer these questions, but we are making a submission to us, which we are going to process. But however, it is us who will ask you about your presentation, then us getting a list of questions from you. We are a parliamentary committee that will listen to all other stakeholders, yourself included, and process your submission collectively with other submissions. May I then, having given you that background, to say, do go to the archives of the Department of Health, see how they process the green paper, that might assist you. How they process the white paper, that also might assist you. We are not at that level now. We are ahead of that. If those processes you have challenges with, then they came at a particular stage, not during this period. May I check, because if there are questions from honorable members, clarity seeking questions, and noting that this presentation is now left with very few minutes for our interaction with, so that we take the next one at the appropriate time. But we nevertheless, I cannot allow members to ask questions from this presentation. Honorable members, please give your names. I will allow you to either raise your hand on this platform and then I'll recognize you, or you just shout the name here, I'll note it.
My name is Petros Macho.
My hand, I have asked on the group for questions, please, Chair, Honorable Wilson.
I've also asked a question, Chair, on the group, Sokacha.
I had the name, was it Dr. Tembekwa who came first?
It's Wilson, Chair.
Oh, Honorable Wilson, number one.
And then I'm number two.
Yeah, number two. Honorable Dr. Kenny. Dr. Kenny is number three. Honorable Kela, number four. Any other hand I'm leaving behind? Any hand that I'm leaving behind? Mr. Mzanya, you will take all the questions at a time and then you can then reply at once. Let's start, Honorable Wilson.
Thank you, Chairperson, and thank you to the Khayelitsha and Klipfontein team for your presentation. Just more clarity. You have said that in principle you support the NHI, but like every other report we've heard and every other presentation we've heard, you will support the NHI in principle, and this is followed by a whole lot of issues or things you insist or believe must be included in the report, and a lot of these have been relevant. So one of the ones that does keep coming up is the establishment of the board by the minister. And this is something that's been raised by every presentation we've had to date. And every sector wants a presentation or representation on the board. How do you believe that this should be managed? Because one of the things you raised was monitoring and evaluation. A lot of the monitoring and evaluation that is going to go on throughout this NHI process is obviously going to fall on the board, because the board is going to have to do a lot of monitoring and evaluation with regards to the rollout. And if not everybody is represented, not everybody is going to be happy. So I would like to know how you suggest that that should happen. The other question I have is, and you talked a lot about municipal, you talked about district responsibilities, you talked about provincial responsibilities. Now, in the NHI program, principally a lot of what is currently being done in the medical circles in the health sector at the moment is, you know, the budgets are divided and they are given to provinces and to various NGOs or whatever it is. However, under the NHI, everything is going to be centralized. In other words, it's going to be a centralized purchasing. So everything is going to be done by one point. Now, obviously, our concern is, or one of the concerns is that obviously with the current talk about all the corruption that's gone on in the health sector, which is quite hectic. How do you feel about everything being centralized? You have asked for a guarantee that we will not be open to state capture. However, anything that is centralized does leave us open to question. So yeah, I would like responses on that. Thank you, Chair.
Thank you very much, Chairperson. Let me also welcome the presentation from the Khayelitsha Forum. I've got two questions, Chair. The first one, I heard the presenter mentioning the question of feedback. I just want to check from the presenter, what is the nature and form of feedback that they are expecting from government following the green, the white, and the draft bill consultations? That is my first question. My second question, Chair, is around the health committees. Are health committees not defined in the Health Act? Can the Khayelitsha Health Forum suggest on how health committees should play a role in the DHMOs? Thank you very much, Chairperson.
Okay. Honorable Dr.
It's me, Chair.
Oh, sorry. Sorry, it's Honorable Kela first. Okay.
Yes, thank you very much, Chairperson. Let me welcome the presentation from Khayelitsha. Indeed, we really appreciate your input and how do you see the implementation of NHI and also areas that the NHI must cover. I'm very happy with the presentation, and also I welcome the presentation. But I'm also having a few questions that I want to ask from the presenter. My first question, do you think there is a role for private sector under NHI? The second question, what do you think of Section 48 and Section 49 in terms of financing of NHI? Those are my questions that I want to ask to the presenter. But thank you very much, Khayelitsha.
Thank you, Chairperson. Thank you for the presentation this morning. We really appreciate you coming to do this presentation. You mentioned a number of things, so I just want to raise two of the points which you raised. The one was on building up the public health system. And so my question to you is do you think that there should be a prerequisite before the NHI can be implemented? And what are you proposing on building up the public health system? Then my second point would be on the socio-economic impact assessment. Since you had spoken a number of times about stakeholder engagements, so are you aware that there is a socio-economic impact assessment called the SIAS report that is a public document, and that it also provides a report on stakeholder engagement? Thank you, Chair.
Thank you. Thank you, Dr. Jacobs. I just wanted to check whether Thanks also for the presentation. I wanted just to check whether Health Forum, Culture Health Forum, are aware of something that is on the bill, section 27, that talks about, I'll read it here, everybody has a right to have access to healthcare services, including reproductive health care, sufficient food and water and all that. Now, if NHI is based on this fundamental principle, which is on section 27 of our constitution, now, will that not be sufficient? Now I hear that they would want to have in the bill a comment about children, a comment about elderly, a comment about people with disabilities. If the constitution is saying everybody, and it means everybody. Now, what is the challenge with that? Because then once you start listing, then we are going to be listing other people. But if it is based on this thinking that it says everyone has a right to have access to healthcare services, is that not adequate going forward? The other thing, I'm not sure whether eHealth Forum is able to give an undertaking that if, however, maybe they were not able to be participating in the hearings in whatever form, whether green paper, white paper, or this one. Of course, now they are here because they are able to participate, whether they can then conclude that in the whole country, everybody has been left out, because the South African population is quite big, and you can do so much in advertising and asking people to come forward, and they do come, but others don't. Now, you would probably be saying, should you have got the 40 million South Africans to have said something, 52 million of the South Africans to have said something? If they're not, then we are not able to move forward. Are you making some of those suggestions? Then maybe you can then assist us with the responses. Thank you very much.
Thank you, Chair. Let me start with your comment about the green paper and white paper. The consultation of stakeholders was not done enough. We just heard about the green paper and the white paper. So that is why now we are saying, if that consultation with stakeholders in our communities, those consultation process should be available, and then the reports that we should see the reports. Then also the NHI consultation process done in a way that other communities didn't manage to. For instance, the closing date in the Western Cape was before the Western Cape consulted. I think when we were submitting our submission early last year, we're also saying that the closing date should be after the consultation process. So it was mentioned before the consultation process. And then I'll leave to Comrade Mato to talk about the board issue of that minister is appointing the board.
Let me start by saying good morning, everybody in the Parliament. It's good to see you, and we welcome the call that you have made for us to come and present. What I'm going to say is that if you talk about the health minister being able to appoint special clinic committees, our saying that is that the people that are appointed by the minister are accountable to the minister, and that on its own is not a public participation in our view, because the community will never have a voice. Whatever comes out as a problem in a facility, that problem will always be put under the mat, because those people are accountable to the minister. They will not be able to expose it. in terms of bad things that are happening within the facility. Hence, we are saying at least with those that are at local based, especially clinic committees and the hospitals that are within the communities, at least the community should have a say and able to make the facility managers and ministers accountable so that at least the services that are being delivered to those facilities are delivered in a manner that the community is happy with. We know not everything will be perfect, but at least the community should be able to play a role in that effect. That's why we're saying it is not on for the minister to appoint the health committees. Maybe for the board, because the district hospital is a big thing, he can appoint, but if you're talking about the health committee, a health clinic, at least facilities, very small community participate there, can be given a chance to participate. That's what we're saying. Also, in taking a bite to what you are saying in terms of public hearings, the problem with the public hearing is that sometimes you get to hear about them when they're already closer to the date, so you don't have a time to prepare yourself to go and present to that. That's where the cry is, because when you had the time for the date with the Khayelitsha, when that was done in Cape Town, it was already very close and we couldn't have time to prepare, whereas we thought if we were given much more time, we would have prepared a better presentation so that at least when you go to public hearings, it is taken into account so that at least everything that is done, because we believe sometimes other things are right in paper and presentation, but in terms of implementation, they do give problems. That is why we're saying the public should have a say or being able to make the public servants accountable to them. Thank you.
In question that the feedback from nature to the stakeholders, I think when we as we done or the government done the health sector in consultation about NHI, that was good because you go all over the country and give a chance for the people to have their inputs. As you were here in Khayelitsha, because we're part of that one, we can witness that. So I think the form of feedback in the communities should be, once we include the civil society, the information is going to flow to everyone in the community. Health committees and other stakeholders will be having the information in terms when we go back to give a feedback. In the committee that you're talking about, maybe the board that is inclusive of civil society, then that would be the partnership between the government and the communities. Building healthcare system. Oh, another one. I think it is very important to have a private sector in the NHI because there is a lot of work that need to be done. Also, there are different kind of people in our communities. Now for the service delivery to ifikelele ebantwini bonke, it is important that we have the private sector. Building the public healthcare system, as we mentioned that provinces and district and municipalities should work hand in hand with stakeholders. And like in our communities, we've got health committees that are not recognized by the government, but I mentioned in the Health Act, but what role that should be played by the health committees, it should be clarified. Now we're facing a situation that minister is appointing the clinic committees, for instance. There is no committee participation on that one. But when there is problems, now health committees has to get in. So when we're building the system down in the municipalities, we should include all structures. And also you are not going to get that issue of blaming one another or shifting blame to, they're going to say this is for the province, this for the region, whatever that is going on. So in building the public health system, we should include everyone. I'm fully agree with you, Chair, that the Health Act mentioned that everyone has a right to health. But sometimes the challenges that we are getting in our communities, you find that the health is owned by some people, certain individuals, and people are queuing there, ending up not getting the services. When you go in our communities and clinic, if you can do oversight, you can see a very bad situation. People wake up in the morning, go to the clinics, and come back without getting any help because there are a lot of people, some facilities taking a number of people. So that is not everyone has a right to help. So they cannot get the service that they expected. As much as the document saying we've got the right to help, everyone has got the right to help. Thank you.
Okay. Any other honorable member that wants to ask a question? May I also assist to the leadership of the Health Forum that maybe if you accessing the website of the parliamentary website and also the Department of Health, just check the presentation that they made to us. Maybe you are correct. I don't know whether they made it to all other members of the public, but as a portfolio committee, we requested that NHI pilot site report, and then you can pick it up there if they did not actually made it public to you. But we are glad that the department is also here. They're listening to your presentations. Any other?
Very last question from me, Chair, if you permit.
Yes, Dr. Jacobs.
Just a question on the clinic committees. The presenter was saying are appointed by the minister. According to the National
Recording
Health Act,
stopped.
we know that MECs appoint clinic committees.
Recording in progress.
If you can maybe just acknowledge that, and maybe elaborate if you
Recording
want.
stopped.
Thank you, Chair.
Recording in progress.
Okay. Okay, that's just another point of information. Okay. That some of these issues, maybe they are covered well in the National Health Act as to who does what. I'm just imagining there are about maybe 3,000 or more, 4,000 clinics in the country. If all of them were to be appointed by the minister, yeah, so probably that is one area we just need to go and check whether it is not delegated. Maybe Honorable Jacobs is referring us to that, just check that document. It may be that there are, in fact, I think there are delegated to the MECs to appoint clinic committees. Any other member, any other point to raise? Okay. Okay. Look, we are grateful that you came to present to us. We will look into your presentation. It will enrich our discussion as a portfolio committee when we actually take all the presenters that have come through. Sorry for that hiccup that you faced, and we will always be grateful when people try and make an effort despite challenges that they face in the connectivity to come forward. Mr. Mzanywa and the other leader, if there is any last closing comments you'd like to give, we will appreciate that.
Thank you, Chair. Thank you, Chair. Siyabulela nge-opportunity enisinika yona, and also the portfolio committee give us a ear to listen to us. We thank you very much.
Siyabulela apho ke hambani niyoqhuba inqola ekhaya. Enkosi kakhulu. Thank you.
Enkosi kakhulu.
Miss who's now, maybe she's back on the platform now. Miss Machalamba, can you fly to the agenda as the members exit so that we can check how much time we have before the next presentation. Presentation, okay. Okay, honorable members, may I request that the presenter started 10 at 15. It's now about, oh no. Okay, we'll leave it at 20 past, yes. But can they make sure that the presenters log in on time, Professor Saluji, and have your presentation shared with whoever is going to be showing the slides, so that when we reconvene at 20 past 10, we just start. We don't really have to get the logistics of logging in and putting a presentation to be seen by all of us. Thank you.
Thanks, Mr. Chair. We're all ready to go, so we will be on time. Thank you.
Okay, we then should be welcoming the leadership from the Children's Institute in the University of Cape Town. They will introduce themselves and then start with the presentation. So the minute of just before 20 past will be for their introductions. In a lighter note, I just thought their heading was not complete. Where are the children in NHI? I wanted to just say, where are the mother's children in NHI? So they want to talk about children. Okay, leadership, you can start, introduce yourself and then do your presentation.
Thank you. Thank you very much to you and to the Portfolio Committee for this opportunity to advocate for child and adolescent health, in fact, to advocate for maternal, neonatal, child and adolescent health in NHI. My name is Laurie Lake. I'm a communication and education specialist based at the Children's Institute at the University of Cape Town. And this is, in a sense, a joint submission from a range of child health advocates and pediatric specialists from around the country. So it gives me great pleasure to introduce my co-presenters, Professor Haroon Suluji, from the Department of Community Pediatrics at the University of the Witwatersrand, and Professor Tony Westwood from the Department of Pediatrics and Child Health at the University of Cape Town. In addition, we have a number of other colleagues on the call who will be joining us for the question and answer session after the series of short presentations. And that includes Professor Louis Reynolds from UCT, Professor Widad Slemming from the University of Wits, Professor Diane Gray from the University of Cape Town, and Dr. Chantal Witten of the South African Civil Society on Women, Adolescent and Child Health. So we really thank you for your time. And I'm going to dive straight in because I know that we could all talk for hours about child health and we have very limited time. So thank you.
Ms. Laurie, let me just give you this heads up. For all of you presenting, you have 45 minutes to make your presentation. Then we'll engage the Portfolio Committee. Okay.
Brilliant. That sounds fantastic. So why is it important to put children at the heart of the NHI? The first motivation is the challenge of poverty and inequality. And we know that children in South Africa are disproportionately affected by poverty and more likely than adults to be living in poor households. Many of our children experience multiple deprivations that then accumulate over time, creating long-lasting developmental setbacks and trapping children and families in poverty. And we know that children in the former homelands and the informal settlements continue to experience the highest levels of deprivation. In 2018, nearly 60% of our children were living below the poverty line. 1 in 5 children were in overcrowded households, 1 in 3 were without water on site, and 1 in 5 were without basic sanitation. And in addition, 1 in 5 children still traveled more than 30 minutes to reach a healthcare facility. We know also that transport costs and safety concerns lead to life-threatening delays in accessing care, and that a lack of positive and caring attitudes has been undermining the uptake of both adolescent health services and antenatal care. It is therefore unsurprising that diseases of poverty such as diarrhea, lower respiratory tract infections and malnutrition continue to be the key drivers of under 5 mortality. Number 2, we know that early investment is the key to lifelong health. While South Africa has made remarkable progress in reducing under 5 mortality, there is growing concern about children's failure to thrive. For example, the slow violence of malnutrition is undermining children's health and undermining their cognitive development, their learning, and their economic prospects, as well as fueling a rapidly growing epidemic of obesity and adult NCDs. And we know that these are increasing the severity and burden of COVID in our communities and on our healthcare system. There is, however, strong evidence that early intervention, starting in the antenatal period, lasting through those first critical 1,000 days of life and then on into adolescence, is absolutely critical and cost-effective in breaking the intergenerational cycle of ill health and in promoting health and development across the life course. Third, South Africa must honour its international commitments. The Sustainable Development Goals have a strong focus on equity and call on states to prioritise the most vulnerable members of society to ensure that no one is left behind. The Global Strategy for Women, Children and Adolescents Health aims to ensure that children not only survive but thrive and reach their full potential. And it recognises that maternal health is a powerful predictor of child and adolescent health. And it includes a very firm commitment to achieve universal health coverage and financial risk protection for the poor. Fourth, a child-centred NHI is a child rights imperative. Section 28 of the Constitution guarantees children's right to basic health services. And this right is not subject to progressive realisation or limited by the state's available resources. Therefore, an essential package of healthcare services for children and adolescents must be prioritised within NHI's baskets of care. This essential package should promote children and adolescents' survival, as well as their optimal health and development. It should extend beyond treatment to include early intervention, prevention, rehabilitation, and palliative care, including for children with long-term health conditions and disabilities. And it should adopt a life course approach that extends from antenatal care through to adolescence. And most important of all, it must ensure that no child is left behind. We also have a number of specific concerns around the NHI bill. The first concerns the rights of foreign children. And we are particularly pleased to see that the bill upholds the constitutional right of all children to basic healthcare services, and this extends to the children of asylum seekers or illegal foreigners. Yet we note that with concern that these children will not have the formal identity documents needed to register as users. Therefore, clarity is needed on how these children will indeed gain access to the service. Second, some children with long-term health conditions or complex care needs require additional essential care that may fall outside what is termed a basic package of care. It is therefore important to clarify if the NHI fund will provide these benefits for children of asylum seekers and illegal migrants. Third, antenatal and obstetric care are key determinants of child health and survival and are regarded as an essential component of children's right to health by the UN Committee on the Rights of the Child. We therefore urge the state to extend antenatal and obstetric services to asylum seekers and illegal foreigners to ensure that we promote their children's health. Our second concern focuses on equitable access to healthcare. If the NHI is genuinely committed to promoting universal health coverage and health equity, then it is absolutely vital to revise the current accreditation and registration requirements so that they do not prejudice those children who are most in need. The bill currently outlines a series of provisions around the registration of users. This includes the stipulation that people must have proof of registration in order to access health goods and services, that this registration can only be done by an accredited provider or health establishment, and that children born to users may be registered automatically at birth, but those who are already born will need to be registered by their parents, and that they will need to provide an original identity card, birth certificate, or refugee identity card in order to register. This raises three concerns, as it creates barriers for undocumented children, barriers for children living with relatives or on the move between households, and barriers for children in poor communities where health facilities are not accredited. We know that just over 1 million children were born in South Africa in 2018. And while birth registration has steadily been improving, only 87% of births were registered in the first 30 days of birth. And these rates decline dramatically when one starts to look at more rural districts. And in total, there are approximately 500,000 children in South Africa at the moment who do not have birth certificates. And of these, 80% are South African citizens. So we therefore call on the Department of Health to consider drawing on the alternative forms of identification that are specified in Regulation 11.1 of the Social Assistance Act of 2004 to ensure that gaps in the birth registration system are not compromising children's access to care. Number two, we're concerned about barriers for children living with relatives. We know in the South African context and following a history of migrant labour, many families continue to be fluid and stretched across the rural and urban divide. As our families seek to balance their needs for work, for education, for childcare and protection, with both adult caregivers and children moving between households. In addition, 20% of South Africa's children do not live with their biological parents. This increases to 29% of African children and 33% of all children in the Eastern Cape. We therefore call on the state to ensure that measures are put in place to enable children's de facto caregivers to register them as users on the NHI, and to ensure that the NHI benefits follow the child in the same way as the child support grant. Third, the accreditation of health facilities pose a potential risk and may indeed increase inequities in access to health care. We know that after 2 decades of public sector austerity, many public health facilities are understaffed, under-equipped, and unlikely to qualify for NHI accreditation. The most recent report of the Office of Health Standards Compliance found that only 1% of the public health facilities surveyed actually met the norms and standards required for certification. And we know that hospitals and private facilities are far more likely to get accredited than clinics and community health centres, and that this process of accreditation is likely to deepen both the urban-rural and private-public health divide. We therefore call on the state to put in place measures to ensure that these accreditation requirements do not discriminate against the most vulnerable members of our society, our children, the elderly, children with long-term health conditions and disabilities, and those living in rural areas, all of whom are dependent on local facilities and need to access care close to home. Lastly, we are concerned around representation for child and adolescent health. We note that the bill enjoins the Minister to appoint 3 advisory committees: the Benefits Advisory Committee, the Health Benefits Pricing Committee, and the Stakeholder Advisory Committee. And we note with concern that none of these structures have representation from child health specialists nor from the children's sector. And this raises real concerns around the extent to which children's and adolescent specific needs are going to be adequately addressed and prioritized within NHI. For example, if we take a look at the national core standards, it is clear that children are rarely considered outside of neonatal and pediatric wards, despite the vulnerability of newborns and children in EMS settings, or the vulnerabilities that adolescents face when they move from pediatric to adult services. Instead, what's quite clear from the Office of the Health Standards Compliance Report of 2015-16 is that there has been a great effort to make sure that the needs of the elderly have been addressed across the full spectrum of standards. And the report actually found that Red Cross War Memorial Children's Hospital failed to meet the standards required, in part because they hadn't got emergency trolleys with adult oxygen masks, nor had risk assessments being conducted on frail and elderly patients. And it's a remarkable set of criteria against which to judge a children's hospital. So we really want to call in the strongest possible terms for representation for child and adolescent health on all 3 NHI structures. And this is to ensure that children's specific needs are addressed in both the basket of care and the formulary. And so that we give effect to children's best interests, and that we make sure that there is a strong voice advocating for our most vulnerable children. Thank you. If I can pass on to Tony Westwood.
Good morning, everybody, and thank you very much for being willing to hear my talk. I'm Tony Westwood, and I'm unable to share my screen at the moment. I wonder if that could be changed. In the meantime, I'll speak to the fact that I've been a paediatrician for the last 30 years working in the public health sector in this part of the world, in South Africa. And I'm here to talk specifically around the essential package of care, or the basket of care that is required. At the moment, I cannot share my slides as I'm not allowed to. So I don't know whether somebody could put up my slides or whether they can give me screen sharing rights, please. Oh, there we go. Thank you very much. Can you see a full slide or the working slides? I'm sorry, I can't see what you can see.
We can see.
Make it a slide presentation, please. Press the button of slide flow.
I think I'll go ahead at the moment because I don't know how to swap from one to the other, but I've got two sets of slides here. So let me go ahead. So thank you very much for giving me a chance to talk this morning. Today's the day after World No Tobacco Day, and it is this very same committee with this a lot to do on your agenda around the health in South Africa, who will be meeting the tobacco bill when it gets back to you. So today is the day after World No Tobacco Day, and we're going to focus on children who are also exposed to tobacco, but that's not the nature of this talk. So this is the essential package of care for mothers and children in South Africa, the role of NHI. And when we say mothers, we also include the fathers and the families who support them. And when we say children, we include newborns and adolescents. So please take that as a shorthand for how we deal with mothers and children in the context in which they work. And I will be looking particularly at why and what and how about the package of care, and focusing mainly on the what's known as the basket of care. So I have a basket down the one side, a Moses basket reminding us of the baby, or a box which represents a package. And the white paper for NHI said that NHI will provide a comprehensive package of personal health services. As resources are limited, delivery of a comprehensive package will take into account the need to progressively realize the personal health benefits while undertaking priority setting. As we heard earlier, this doesn't apply in terms of progressive realization to the basket of care for children, but no doubt within that there has to be a priority. So I'll be talking first about the why we need to develop this essential package of care for children under NHI. And here we are back with section 28. Every child has a right to basic healthcare services. And an interpretation of that is that children must receive those healthcare services that are essential to protect them from commonest and greatest threats to their health, and to restore them to health when those threats produce disease or injury. In other words, basic is not just treatment for diarrhea and immunizations. It is everything that we need to do to deal with the commonest and greatest threats to children's health. So it's about prevention and promotion, as well as dealing with sickness and palliative care, the whole range of things that children would be considered essential. So we're using the word essential in the same way that we have the essential medicines list. In other words, a list of things that have to be there for everybody. So this idea of an essential package of care, which NHI has taken on, has actually been part of work that the Ministerial Advisory Committee on Mortality and Morbidity among Children in South Africa has been dealing with for a number of years, and has done a considerable amount of work on, and does see it as really core to the implementation of NHI, and making sure that the bill and the act itself make sure that this actually happens. And we'll come to how we think this could happen later in this presentation. So NHI, really, this bill is an essential opportunity to make a difference and get an essential package of care that children and mothers will benefit from across the country, and in the situations that we've already heard from Laurie Lake about. So there's good evidence that a package of care does the following. It improves access to care, improves health outcomes, enhances equity, which is vital. You've already heard how inequitable things are. So NHI has a chance to produce equity, or move towards equity, prioritizing interventions that make a considerable difference for the bulk of children, and providing standardized pathways of quality care that are maximally effective for a target population at a reasonable cost. And this has been done in Malawi and Mexico and Ghana, and this is something that we feel South Africa is overdue for doing. We do it in certain areas, but we don't have a comprehensive approach, and NHI allows us to do that. For mothers and children, it's particularly important because we have major gains for lifelong outcomes, can be achieved with relatively simple interventions. And we, has already been engaged with, mothers and children have special health care needs that are not always met in systems that mainly serve adults. So when the NHI bill says that medicine is going to be represented, that people think of doctors, and mothers and children are not necessarily going to be represented by general medical approaches. So what is in the package of care? How does it work, or how might it work under NHI? And if we consider what we said about essential earlier, here is a simple way to look at these things. There will be essential content areas which cover things that are commonly afflicting children across the country, or potentially afflicting them if we don't deal with prevention and promotion. It covers everything from promotive through curative to rehabilitative and palliative, but also deals with how these things are overseen. And we must note particularly that when we think about children, people mainly think about children under 5 dying of diarrhea and pneumonia, malnutrition. But we have 1 in 5 children in this country has a long-term condition and disabilities. And when it comes to basic healthcare services for them, you have to start with the fact that they have a condition and produce basic healthcare for those conditions. And NHI is absolutely correctly designed to achieve this if we do it correctly. We then have comprehensive pathway packages that work from the home all the way through to the most sophisticated care that the child requires in terms of technical sophistication, equipment, etc., medication. And it covers vertical, where it may be programmatic, and horizontal, where it's actually at community level and family level, and including school health. That's what the essential package of care covers. So here's an example of content areas. I don't expect you to read it in detail. You'll have these slides. But really, they're content areas that cover a range of child health. And within that, on the right of the slide, the core requirements that are required within a package, going from clinical guidelines to equipment, to infrastructure, to communication leaflets, to stationery, etc. That's all within the package. And here is how it might look across the whole of the system, from community-based services to regional hospitals, and down the left-hand side, all the things that are included in the package. So it's much more than pharmaceuticals and equipment. It includes stationery and a number of things that we feel we've spent a lot of time thinking about and can contribute to this process. So here's an example for diarrhea, which I'll pass over and you can look at that. So when it comes to the how, our last question, here we are back again saying that National Health Insurance Bill is an essential opportunity for doing this, for constructing an essential package of care, what goes into it and why it goes into it and how it is delivered and what it costs. And so specifically, our request to this committee when it comes to the bill itself and our motivation is that the maternal and child health specifically be presented in the Benefits Advisory Committee by experts in MCH. You heard from Laurie Y, and you're hearing from me Y as well. So either include it in Section 25 as an amendment to the bill as it goes through Parliament, or under the regulations, and this is our second choice, not our first choice, that it's very clear that maternal and child health is represented in that Benefits Advisory Committee, as you've already heard the other committees who would be advising this committee, like the Stakeholder Advisory Committee. So thank you very much. That's it for me. Whether it's a basket or a package, NHI is the way forward, but it has to take account of maternal and child health. Thank you very much. And I hand over to Haroon Saluji.
Thank you, Tony. I'll attempt to share my slide now.
Yeah. I'm afraid I see that, Professor Saluji, you have got 24 slides. Now, you don't have
many of them are
minutes.
pictures, and I'll cover it in the next 14 minutes, Mr. Chair. So thank you very much for this opportunity. And I'm going to be reflecting on one component of NHI, which is already under implementation, and offer some perspective and reflection, and perhaps raise the question, what can we learn about the subsequent promulgation of NHI? So I think we've recognized that NHI needs strong district systems and that the mothers in care depend heavily on primary health care for their needs. And I think the bill has clearly outlined the primacy of primary health care and its re-engineering. And so you won't find too many complaints from us about what's in the bill already. I think there's going to be more reflection on perhaps some of the successes of the implementation of re-engineered primary health care. And I'll remind the committee that when the pilot aspects of NHI were introduced way back in 2011, this featured prominently. And so it's worth perhaps offering some perspective and reflection on this. So I trust most members of the committee are very familiar with what is primary healthcare engineering, but just to remind you that it has 4 main components. There's the component of municipal ward-based outreach teams or community health workers. There's the integrated school health program. There's the district clinical specialist teams. And then the 4th component added 2 years later, in 2013, was the contracting of private healthcare practitioners at a non-specialist level. And what I intend to do in the next 12 minutes is briefly reflect on what lessons we've learned from each of these different aspects of primary healthcare reengineering and what it might portend for the future of NHI. So to reiterate, we believe that within the bill, most aspects of the primary healthcare engineering are captured and are captured satisfactorily. So again, I won't go through the details, but in the memorandum, there's clearly preference and cognizance given to the strengthening of primary healthcare services within a district health management offices. And so, and the focus on preventive, promotive, curative and palliative care is very strongly there. So no complaints about that aspect. If one looks at the particular aspects of primary healthcare engineering, again, it's covered very well. So this whole slide is about the fact that the services need a population orientation and that we need these primary healthcare outreach teams. And it also outlines some of the basics about how they will be allocated, what their responsibilities will be, and the need to extend beyond just immediate health, individual healthcare to community involvement. So no major complaints about how the bill captures that role. It also talks about school health services and reinforces the need to meet the needs from pre-grade R to grade 12. And then the component about primary healthcare providers is also there. It doesn't give a specific paragraph in the memoranda to the district health clinical specialist teams, but in among the articles related to repeal or amendments, it does recognize, but in yellow, that to manage the primary healthcare within a district, you do need district clinical specialist teams. And of course, primary health key teams and school health services. So while not explicitly mentioned in the memorandum, there is recognition within the bill. So coming then on to this slide, which just to remind the committee that when NHI was first promulgated and the phasing in was outlined for the first 5 years, the re-engineering strategy actually was very prominent amounting. So you'll see the initial bits were the legislative process, the role of the Office of Health Standards Compliance. But number 6, 7, and 8 were exactly the aspects I'll be reflecting on now. And so we're not talking about a new program or something in the future. This is something that has been with us now for almost a decade. And so we certainly felt that some reflection on the strengths and failures of this particular aspect of NHI warrants reflection as we plan the future. And that's what I intend to do in the next 9 minutes. So very briefly then, looking firstly at the ward-based primary healthcare outreach teams. What do we know about it? Well, we know we've probably got about 58,000 community health workers. They've extended to all 52 districts. Most have been acquired or appropriated from non-governmental organizations. The problem we have is that there's very little information publicly on what they are doing and also how well they are doing it, how effective have they been. And so for this presentation, I've had to depend a lot on the literature, on what's been published, and I'm afraid there isn't a lot, but that doesn't stop us from offering some kind of reflections, be it somewhat anecdotal. So very quickly then, what would be some of the successes and failures of this particular program? And I think it's a success that we've actually implemented the program, that home visits are happening, and certainly some of the aspects that were done previously, particularly HIV and TB, have continued to be done, particularly looking at antiretroviral adherence. Were there any failures? And I've highlighted 2 from a child health perspective. The fact that there's been limited extension beyond HIV and TB, and that the role of mothers, children in the daily work of community health workers hasn't come through to the degree we would have liked. And also this lack of data on their activities, so unable to say exactly what's been done, including how effective referrals has been, because that's a key function. They are our eyes, ears, and noses in the community, identifying issues and referrals. And so then very briefly reflecting on what have been some of the obstacles. And I'm sure this is something that the committee knows very well, but among those would be the varying degrees of training of these community health workers, their skills and competencies, that coverage hasn't been completely equal, And a particular problem has been the support and supervision they've received within the health system, from the clinics primarily, but also from many other parts or components of the primary healthcare services. And this idea that they would easily extend into community-based services and influence those also probably hasn't been realized to the extent we would have liked. And so there have been no clear coverage targets. And so our assessment then is very anecdotal rather than evidence-based. So then very quickly in a minute, what is the remedy? There's no doubt that globally, community health workers and their role has come to the fore. There are systematic reviews that demonstrate that they can very effectively change many of the outcomes that are key to this committee and to the country, including maternal mortality, child morbidity, but also thrive outcomes beyond survival and the ability to transform the health system. So very quickly in a minute, I've outlined 5 key areas. The one issue is this upskilling and of skills. That still remains a problem 10 years into the program. The linkage with the health service. I've highlighted these as problems. If there was time, and I'm happy to outline some ideas about how each of these could be addressed. The defined scope of activities and how could child and maternal health activities be promoted better. But perhaps the last one, in terms of if we look at their roles, and this is a theme for all the primary healthcare strategies, is the lack of resources. Despite the NHI having budgets and sometimes underspending their budgets, this aspect of NHI has been continually under-resourced, and it's our view that those resources need to be increased. So one of the key areas of resource is the use of technology. We can perhaps in the question discuss how other countries have done it. And India, for example, in the last 2 years have gone very highly on mobile applications for community health workers, extending it to hundreds of thousands of community workers who are walking around with mobiles. Firstly, using it as health promotion, showing videos to mothers, to children, but more importantly, also catching up on information, health information. Moving on, and I recognize I've still got 6 minutes, that the other area is the integrated school health program. So what can we say about it over the last 9 years? A few points. Okay, that at this stage, we probably have about 20,000 school nurses meeting the needs of 21,000 schools. We do the sums, that's about 1 per 1,000 schools. That the services have been provided unevenly. Some districts are fantastic, some are struggling. But again, the resource issues come through, whether it's budgets, whether it's a number of staff, whether it's equipment or transport required. And so the focus has very much been on screening, particularly grade 1s and grade 8. And there's been about a 40% achievement of basic screening, eyes, ears, teeth that's been achieved. So if we look at successes, I think the fact that we've got a screening program countrywide has to be viewed as a success. And we've also introduced the human papilloma virus vaccination coverage, which is part of the responsibility of school health teams. And that's been quite successful, 85% coverage of the first dose vaccine and 80%, which is laudable. But again, many failures, particularly related to resources. We still have a low screening coverage despite having the program for a long time. The health promotion activities are mostly non-existent. The referrals of children picked up is not standardized, and again, so varies district by district. And what's really been of concern to us is the fact that these different components of the primary health and re-engineering strategy, school health teams, community health workers, in many districts don't seem to be communicating effectively. So some of this is resource related, just like community health workers. Some of it is related to how much support at a district level there has been for these initiatives. And so as we look forward, what are some of the key strategies we think? The first would be the issue of, it's not just about coverage, for example, of screening, but we need to start exploring what you've heard many times, quality and impact. Is it really making a difference to children's hearing, vision, teeth, but more important, the educational attainment? And so the fundamental change I think we're proposing is that with this very limited number of school nurses, that they can't be the foot soldiers doing screening. That's not an appropriate use of their skills and competencies. That in fact, we'd like to see them become more managers, handling a team, which includes matriculants, health promoters who could do the task, who could do screening. You don't need to be a nurse to be checking eyes and vision and hearing. That in fact, we get peers, young adults, to come and do some of the health promotion aspects, particularly the sexual and reproductive health. And of course, teachers are beginning to get involved, but they could do the decomming. So a re-envisaging of the school health team with a nurse being basically a manager, ensuring things are happening, the children are getting to the clinic and getting the services they need. Finally, coming down to the district clinical specialist team, some reflections on this aspect. So over the last 9 years, the problem that has remained is that some teams are complete, and the complete teams is an obstetrician and his nurse, a pediatrician and his or her nurse, a family practitioner with a primary healthcare nurse, and then an anesthetist. And so we've still struggled to get complete teams around the country. These are dated figures, 2017, and vacant posts, particularly in the less resource centers. And it's the whole issue of attracting human resources to less privileged areas. But I think the fundamental problem that's been an obstacle to district clinical specialist teams is their ability to extract the accountability that their clinical governance functions have demanded. And there's also been uncertainty in many of the districts about what exactly they should and shouldn't be doing. And because that hasn't been satisfactorily resolved, we see very different outcomes in different parts of the countries. And so when we ask DCSTs why aren't they functioning optimally, they often raise the issues of lack of operational support, too many being demands on them which are not appropriate, and that most importantly, many of these recommendations that have come through have not been implemented. So to finish off then, there clearly have been successes in the DCSTs. They've become these bridge builders, the intersection between different components of the health system. And there are some excellent reports of their achieving successes. But again, we don't have a composite picture of that. The biggest failure, I think, is their ability to be able to extract the accountability that their governance function demands. And also I raised the issue of linking with others. So then I've got a minute left. What are some of the key things? We certainly believe all three arms need to be continued, despite what I've raised as some of the obstacles and failures. We believe that in terms of NHI, as we go forward, they all need it. And perhaps the key thing for the district clinical specialist teams is a greater focus on this clinical governance role. And one of the deficiencies that we have advocates have highlighted over the years is that while you have these district teams, the most successful provinces, particularly KwaZulu-Natal and Limpopo, have had a provincial specialist who coordinates the various district teams. The NHI bill is a bit silent about that provincial coordination, but we believe that the recognized success has been because of the ability to link not district clinical specialist teams, and that's been something that's been missing for a while. All right, I recognize that I've reached my time limit. I wanted to highlight what this clinical governance meant. It's not critical, it's in the slide, but I think that's the role we'd like the DCSTs to particularly take more responsibility, because that's what changed systems. I'm not going to talk at all about the contracting of private health practitioners, not because they're not relevant to children, but I trust the committee is going to get many, many inputs on this. All I want to say is that we've recognized that in this austerity environment, because budgets are being cut, this is the one component that, in fact, Treasury has said there will be more funding for. We are, of course, a bit concerned that the other elements are equally important, but this is being prioritized. We recognize there's a need for prioritization. We don't necessarily see this as the most important. So to finally summarize this slide, the primary healthcare re-engineering strategy in 2011, this was an article that said, is an essential but not a sufficient condition to achieve improved health outcomes, and we agree with that. It has to be accompanied by a change of culture that incentivizes system-wide planning and implementation to achieve desired outcomes. And I think that's the reflection I've offered, that perhaps that change of culture, that system-wide planning, and that implementation has not been to the extent we would have liked. And that's the challenge for NHI as we go forward. Transforming a district health system requires current ongoing programs needs attention as much as new programs. And that, I think, is the challenge. I'm not going to read my conclusion slide. I think the reflection I want to say in this presentation really tried to offer some perspective. We are motivating for the continuance of the primary healthcare strategy as proposed in the bill. We think it has achieved many things that we can be proud of, But I think we've needed the two things. There's highlighted the need perhaps for a more critical review of what has happened and how these lessons can influence those as we take NHI forward. Thank you very much.
Is that the last presentation?
Yes, this is the end of the formal presentation.
Yeah, Professor Saluji, I would want you to go back, read your conclusions, because we need that recorded. I now realize we should have given you more time because there are more presenters. We were not aware. So just go back, read your conclusions for
Happy
the
to
record.
do that.
Yeah.
Yes, happy to do that. I'll share my screen in a moment. Shucks. For some reason, I can't share my slide. Would you mind if I just read them rather than just to save time? I'll read them and instead of
just read them. Yeah.
Yes. Oh boy. Please give me 10 seconds of just trying to. Oh boy. Sorry, Mr. Chair, I've just suddenly had problems with opening the document, so I should be there in 5 seconds. So the concluding remarks are 3. The first point is this fact that this experience has been inadequately documented, and so many of the perspectives and reflections I offered are not necessarily based on strong evidence, and clearly that's something as we go forward with NHIs, these activities will need better documentation. The second conclusion says that similarly, while the individual components seem to be evolving spontaneously rather than through continuous systematic review and strategic planning. And so these activities have happened, but we are left with a sense that they could have been better coordinated and more time spent on dealing with the recognized obstacles and failures. And so what really the third point in this slide was that we have presented an argument that we think a re-envisioning new directions are needed, need to be carved for the re-engineering of primary healthcare strategy. And our fear that failure to do this rethinking may result in the loss of a few hard-won successes and a collapse of the initiative. So we are still fully behind this initiative, but we do believe that perhaps a more formal review of aspects of it, or of the program, are needed as we move forward. Thank you very much, Mr. Chair.
Okay. Honorable members, I just checked with the secretary that maybe this was a team that we were not aware, we didn't check, they were coming in with 3 presentations, but all talking to one program, and therefore, but had more time that we allocated to them. There may be time allocated to them more when we engage. I have the following honorable members who have requested to engage, and they're coming in this order. For those who have not put up your hand, please do so. I see some of the hands are coming in on the platform. The first member that will ask is Honorable Wilson, and the second one, Honorable Sokacha, and the third hand that I've seen is Honorable Munyai. Are there any other hands other than these 3 that I've read? First one being Honorable Wilson, the second one, Honorable Sokacha, the third one, Honorable Munyai, and the fourth hand now, who has come also through, is Honorable Gela. And Honorable Gela will be followed by Honorable Dr. Jacobs. Those are the hands that I've seen and I've recognized. Please let us start in that order. Thank you.
Thank you, Chairperson, and thank you very much for the team who have presented today. I think it was a very insightful presentation, a lot of which we know, but I think having it reiterated is always very helpful. And there are concerns, and we hear your concerns, and I support a lot of your concerns. I think that in 2018, 60% of the children were living below the poverty line. Has probably, and COVID has not helped us, that figure is probably escalating, particularly in light of the fact that the unemployment rates are escalating alarmingly. And we are very firm in our belief that the grants that are offered to families, the child support grants in particular, as well as those for the children and people with disabilities are pathetically insufficient. Keeping in mind that families now are being forced to live on a child support grant. It's not going to the child itself, it's going to entire families. And I think this really, you talk about the long-term health problems. And I think this is of grave and serious concern, because a child stunted today is stunted for life. And I think what we're seeing now is an escalation of what could be long-term health problems, lifetime health problems as a result of the current situation. And I think that is alarming, because an unhealthy population is an unproductive population. People who are ill, people who are malnourished, people who are suffering are unable to be productive. And when they are unable to be productive, they are unable to assist the economy of the country. And I think this is going to have very, very long-term results on South Africa as a country. It is concerning that only 1% in the report of current facilities in South Africa met the norms and standards that will allow them to register as NHI facilities. And that is, that is, number one, is very scary. But I think what's even more scary is that we have seen, and we've just done the budgets, that there has been a cut in primary healthcare budgets, cost of employment. In other words, we're already having limited staff. This cut in these budgets are now going to exacerbate that situation, where we're going to see fewer and fewer people being employed in the health sector because of these budget cuts. And one of the cuts, of course, was in infrastructure. And you have talked excessively about inaccessibility and how far people have to go to travel to get healthcare. We know that in a lot of the provinces that we visited, the mobile healthcare units don't even go to wards regularly. People can't even rely on that. So we are sitting, I think, with a very, very scary situation. So my question is this, and any one of your members can answer it. In light of these things, if the NHI was passed tomorrow, knowing that only 1% meet norm and standards, knowing that primary healthcare budgets have been cut, knowing that cost of employees have been cut, knowing that infrastructure budgets have been cut, if the NHI was passed tomorrow, would it work, or should more be done on getting proper infrastructure, accessibility, staffing, and primary healthcare services first? Would you advise? Thank you.
Thank you very much, Chairperson. Let me also welcome the presentation from the team. Chairperson, just one question. I just want to check from the team that in as far as benefits of the advisory committee addressing maternal health and child health, does the team think that they should be included in the bill? The reason is that when services change, it will require amendments of the bill. These should be addressed as part of implementation. Thank you very much.
Oh, have we forgotten who follows Honorable Sokacha? Honorable Munyai, not available.
I'm here. How can I not be available? Sorry, Honorable Chair. But the first issue, Honorable Chair, you said I'm number 4. That's why I was waiting. So, Honorable Chair, the issue of the budget cut, we have expressed it during the budget review process, that the budget cut, massive budget cut, was as a consequence of the neoliberal austerity measures. And we even made a call as this portfolio committee that we must invite Minister Tito Mboweni because to attend to the issues of the budget cut. So, and the problems that are happening now, Honorable Chair, during the COVID-19, is exactly the reason that why we need the NHI, because one country, one health system. We cannot afford. I'm trying to ask them, the presenters, do they think that instead of one healthcare system for everyone, rather than the two separate systems, one for the rich and one for the poor, do they think that is the key model to continue with the status quo where we have the two tiers of healthcare system? My second question, Honorable Chair, is as follows. I just noted it down here. With regard to child health forms, isn't this part of the comprehensive healthcare benefits? Will it not make it better sense that the child and adolescent health be articulated in a regulations or implementation plans instead of the bill? Because that could be confusing if you put in the bill, because we know this is part of the healthcare system. I think they need to clarify. And the other key issues, Honorable Chair, is that we want to understand from the presenters, are there any international best practices that NHI can adopt to mobilize additional funding to cover children for undocumented immigrants or asylum seekers? Do you think the UN family should play a role to provide funding for the services like they do in other contexts? If they could really please assist us in this context, because if they answer this first question that I've also started with, Chair, it will be better, because whether they think that we need to continue with the current two-tier system of healthcare rather than the one single system that covers everybody regardless of unemployment status or rich or poor. Thank you.
Number 4 is Honorable Geller.
Oh, thank you very much, Chairperson. Let me also join my colleagues by welcoming the presentation. And also, I will go just straight to my question, Chairperson. My question, I just want to check with the presenter that do you support the NHI bill explicitly? That will be my question, Chairperson, but thank you very much.
Honorable Dr. Jacobs.
Thank you, Chairperson. Let me also just thank the presenters. We really appreciate them coming. They've given some very valuable input as far as the health of our children are concerned. So we really appreciate that. I do have a number of questions for them, but it's all related to the district health management offices and care at the district level. So do they envisage that the DHMO will fit into the primary healthcare re-engineering under NHI? And then second one is just to bring to them their attention that the NHI bill is not silent on the coordination at the local level. It is actually articulated in section 36, where the DHMO is charged with coordination of primary healthcare provision for personal healthcare at a district level in line with policy guidelines. And then as a very last question, to ask them whether they're aware that the Department of Health and the Office of Health Standards Compliance are implementing the National Quality Improvement Plan. And only facilities which, of course, meet the accreditation requirements in the bill are then found fit for that purpose. It is for that reason that the NHI is implemented incrementally. And just a reference to the British system, the NHS system, when they had no money, they implemented the NHS system, and the system was not ready at the time, but it was also implemented incrementally. And today, it is what the British say, save the NHS. They take great pride in the NHS. Thank you, Chair.
Okay, thank you very much. May I also get an opportunity to ask our presenters? Thank you very much for your presentation. You would recall that I made a joke about your presentation in the first slide to say, where are the children in the NHI? I'm now following it formally with a question. How do you propose that maybe there should be funds raised for a potential flooding of undocumented immigrants who may want to access maternal and child health in our country? Of course, there are extremists in the country who are saying, why do you have asylum seekers and the foreigners in our NHI? Of course, you know that the South African Human Rights Commission will have to accommodate them, but your contribution is also on the other end, far more than what the NHI is proposing. You are proposing this comprehensive maternal and child health even for undocumented immigrants and everybody who's within South Africa, documented and not documented. That's one part. I think the department here is listening on the other day. They will also indicate, because you are right, the registration has its limitation. What do you do with someone who's not registered but needs to access? But that one I need your comment on. The other part I would like to check that on the bill, section C.4.1 is talking about all children, including those of the asylum seekers or illegal immigrants, are included in the NHI. Now, are you not comfortable with that, or you feel that one, some of them are left out, or number two, what their services they are getting maybe is not comprehensive as you would have wanted to? We think you just need to help us to understand this broadly, so that when we collectively get all the views, we can be able to understand your main emphasis here. Thanks. Can honorable members lower their hands so that I could then be able to take, after these responses, if there are new hands or follow-ups? I will appreciate that. I'll then be able to see that is a follow-up hand. Come, presenters, give us your input. Or again, I'm actually wanting to confirm with them, Professor, I think Professor Withhood, yeah, if I'm pronouncing his surname correctly, that you are amenable, but one of my colleagues have asked that if some of these would not appear necessarily in the bill, you would be comfortable to see some, you'll be comfortable still to see them in regulations. If you could also just confirm that. Honorable members, Honorable Kela, your hand is still up, Munai is still up. I will take you a second round if you want, but you can keep them there if you want to ask, or lower them now, we'll take in the second round. Thanks.
Thank you. Could I ask our colleague Louis Reynolds to respond to question 1? You're currently on mute, Louis.
Sorry, thanks very much, Laurie and others for the presentations and for the opportunity to address the Portfolio Committee. The question was, if I remember correctly, if the NHI were to be implemented now or today, would it work? I'm sad to say I don't think it will, for a number of reasons. The public health system is moribund, as we all know. We can see it every day. The private health system is more or less sequestrated, in other words, protected from South Africa's health crisis, and has not been playing a role for many years in dealing with effectively helping dealing with the burden of disease. The ability of the state to manage large funds is also not guaranteed by any means, as we hear daily in what's happening in the Zondo Commission. So I'm afraid I'm a bit pessimistic about the NHI, although I think it's the only way to go. But it has to be done in a way that mobilizes all South Africa's health resources with one objective, and that is to improve the health of the nation. And that includes not only curing individuals, but treating the nation through social solidarity. I think we have to realize that it's not a technical exercise. It's both a technical and a political exercise, and there's a long way to go. I think, over the last, I don't know, since for centuries now, we've been going in the wrong direction regarding health. We had some opportunities to improve the health system, but we've missed them, and we're so far now from where we're supposed to be that we don't even know how to get there. It's a big mountain we have to climb. So I don't think the NHI can work right now, but I do think that it is the only way to go, and it is the way to develop one single health system for all that treats everyone, provides healthcare according to need rather than means. Yeah, that's over. I'm happy to take further discussion on this, but that's my feeling at the moment.
Thank you, Louis. I wanted to respond to question 2, which, as far as I understood, was a question around whether representation for maternal and child health should be included with the Benefits Advisory Committee. I think what we're saying as a collective is that we are concerned that when there isn't explicit representation for child and maternal health, that there is a very real risk that the specific needs of children and adolescents will be overlooked, and we've seen that in a sense in the norms and standards themselves. We know that it's a real challenge. Looking at the formulary, you need someone who's a pediatric specialist because children's needs are different to adults. The staffing needs are different. The equipment needs are different, and there needs to be someone in each one of those committees who is really attuned to children's specific needs and who is actively championing them. And so we would be calling, certainly as a first recommendation, for that to be explicitly noted in the bill in terms of the composition of those 3 committees. And then moving on to question 3, I think Louis already spoken quite strongly around both the challenges of getting NHI up and running in the current context, but also our belief that it is absolutely vital to provide universal health coverage and to address the inequalities that are impacting in fundamental ways on children's survival, health, and development. So certainly in support of the NHI. I think that's question 3. And as part of question 3, there was a question around sources of funding for undocumented, or for services for undocumented asylum seekers and or foreign children. We believe that that's something that the committee should be exploring, ideally with support and guidance from the UN. But in terms of equity, we have a responsibility. Also in terms of Section 28, to ensure that all children have access to healthcare services. I'm not quite sure who wants to take on the next question.
Laurie, let's do it this way. Take the questions that you are able to answer them and exhaust your list. Whether it's question 7, 15, or 20, we are done. Then we move over to another. Let's do it that way. It will be much faster and better.
Yeah. And then you were also similarly, I think, concerned around the potential flooding of undocumented foreigners streaming into South Africa to access maternal or obstetric services. We believe that it's absolutely vital for those children to access care. That right is upheld by the bill, and therefore, by extension, it should be extended to antenatal and maternal care. So that's, I think, the responses from my side. Arun?
Thanks, Laurie. So I think there were some excellent questions, and to do justice, I'll give relatively glib answers. I think many of them are quite profound and need discussion. Let me deal with some of the ones I heard. I think the first question was about if you had to start prioritizing changes at a district level, the primary level, would you focus on infrastructure, or would you continue looking at some of the services and processes? And certainly my view is that infrastructure is always an issue, but I think it's our delivery of service that needs prioritization. And it's those words we use often, like efficiency, accountability. I think that in practice is the real difficulty. So I think the money doesn't necessarily have to be spent on building better clinics or better school health services. I think a lot about it is trying to get our existing services to function more efficiently. Human resources may be an issue. The one we didn't perhaps highlight is that while we have many community health workers, there's a feeling that the current model of 1 in 250 households may not allow us to do what we want to do, and that ratio needs to be different. I know Professor Sanders, late Professor Sanders, often said 1 in 20 using international models might be appropriate. The next issue was the issue, I think, a commitment from us. Are we interested in one system or 2 tiers? And I don't think any of us, any child health advocate doesn't believe that the principles of the NHI are fundamentally correct. I think the difficulty is this committee meets. And that's the issue, is how do you amalgamate these 2 systems? What are the ways we can make this 2-tier system into a 1-tier system that works? And so I don't think the philosophy is of any concern to us. I think this issue, my issue on this issue of extending services to non-South African children is an important one. And 2 comments there. The one question is, are we aware of any international best practices that can guide us on this issue? And the truth is, when we have looked at this, there are many different models, and different countries, including highly resourced countries, sometimes are very stingy in sharing resources, and some are very benevolent. But I think the question is, could there be external agencies like UN agencies that perhaps could offer support? My own view on that one is that it's up to us as a country to decide, firstly, what's basic health services, which the NHI bill clearly accepts will be afforded to non-South African children. But I think the point that Professor Westwood made was that we want an essential package of care, which is beyond the basic. And the discussion point is that the non-South African children, how much of that, not the basic, but the essential package could be extended to them. And I think the chair raised a very pertinent question, is that we not only saying children, but we wanted to move it to mothers. Why? And I think the fundamental argument is if we start off at our starting point is children, then you're already at a disadvantage, because a lot of the problems that newborns, we know how high newborn mortality is a result of the mothers. And so you're starting in the middle and you're already dealing with problems like a preterm infant, which if you had offered antenatal care to the mother might have been preventable. So we recognize it means more money and resources. But I think that's the challenge for the NHI in our service, is saying as a high middle income country, beyond a basic package, what more that we think we can afford. But I can't offer immediate and international best practices that I would say, why don't we emulate this country? Because they do vary quite widely. One last point I'll deal with before handing over to Tony. And I think there's a question about the DHMO. Does it offer anything to primary healthcare services and specifically the primary healthcare strategy? And for me, what it offers is this idea of decentralization. I think as a country, we've really struggled for the last 20 years for firstly districts and district systems to be able to support primary healthcare. And for me, fundamentally, it's a reason about where power is. And so I've said it in many fora. It's not my view. It was reported way back by 2009 by the Risville Committee that power and fundamentally money are too centralized to provinces. And the real strategy is how do we get districts firstly to get some of that power and the money. And if we can get some of that going, then many of these services like school health services and community perhaps could be done. So I think that the bill has got it right. That the challenge again is how do we decentralize that power from provinces to districts. I'll stop there and hand over to Tony, Mr. Chair. We've still got time.
Thank you, Haroon. I fully endorse what you've just said. I'm just going to respond briefly to the chair's question around, are we talking about things in the bill versus regulations? And I think when it comes to the nitty-gritty and the organization of certain things like packages of care, then it is to do with regulations and relating to the Office of Healthcare Standards, for example. But when it comes to representation, the closer that we can get into the bill for certain things around maternal and child health, as we've described, the better they are to actually be reinforced at all levels, from the national level where we have the big fund, right down to the district level as described by Haroon. If everybody knows along every level that they have this particular responsibility for maternal and child health for all the reasons that have been described over the last hour or so, then we are in a much stronger position as a nation to do the right thing by children, but the right thing by the next generation, etc. As they grow up and as they have children themselves. We didn't talk to adolescents in great deal, but I'm hoping that they're here by the noise that they're not making, but should be making around the next generation and their reproduction and becoming mothers and fathers themselves. So yes, we need to be in the bill, children and mothers, that's not me, I don't need to be in the bill, and regulations to make sure that comprehensively they are held and we are held accountable. Thank you.
Honorable members, thank you very much. Unfortunately, we may not be able to have a follow-up questions, but I want to thank the presenters who have been so educative to us. They look like really teachers. I mean, we have been really assisted in understanding some of the things, but I like these last comments that talk about a healthy baby, a healthy child will have to start with a healthy mother. So care for the mother necessarily will, antenatal even before, will necessarily give rise to a healthy nation through babies and all that. We take your presentation and it will assist us as we amalgamate your presentation with many others that we are processing. Thank you very much. You are now released. We enjoyed your listening to you. May we then get the next set of presenters? Can you fly to the agenda, Ms. Machalamba? I think it's a South African psychoanalytic South African Psychoanalytic Confederation. We are going to be learning something about psychoanalysis. All right. I would imagine the presenters are already on because we have already taken 5 minutes of their time. We will bring back your 5 minutes. Professor Wiswood, please stay put. You are not the main presenter now. Let us get those who are presenting from South African Psychoanalytic Confederation to come to the fore and indicate who they are and then start their presentations. You've got 45 minutes to make your presentations. Honorable members would like to engage thereafter with your presentation. Thank you very much. Your 45 minutes starts now.
Thank you very much, Chair, and thank you to all present, all honorable members and colleagues alike. I'm going to introduce myself very briefly and very shortly, and I'm going to ask my colleagues to also introduce themselves who are joining us today on behalf of the South African Psychoanalytic Confederation. And then I will again maybe give 2 sentences around the configuration of this confederation. And then we will lead into a presentation that we've prepared, which is supported by a PowerPoint and another audio-visual supplementary component. And then hopefully we will leave enough time for engagement and conversation, because I think most of us are here to do that. And I also think it's an occupational hazard. So you'll forgive me in that regard, that we do like to engage and to speak and to listen. So I want to leave enough time for that. So my name is Zamo Mbele. I am a clinical psychologist and a senior psychotherapist in Johannesburg, working also as a supervisor teacher trainer at Tara Hospital, which is a tertiary public facility. I am also the deputy chair of the South African Depression and Anxiety Group. I'm a member of the South African Psychoanalytic Association Confederation and a candidate psychoanalyst. I'm going to ask my 3 other colleagues joining us today to introduce themselves ahead of us proceeding.
Hi, thank you everyone for inviting us. We really appreciate it. My name is Coralie Trotter, and I'm a clinical psychologist and a psychoanalyst. I've been working for just over 30 years. I do have a private practice, but I have worked in the community and with state throughout my career, except for a 5-year period where I had my son. So I have a lot of exposure to community clinics, trauma groups, things like detainees counseling service during the apartheid time, crisis clinics, and most recently, I've been quite involved with the clinics again because of COVID. And just before that, I led the team that did the Life Esidimeni arbitration, which I think is one of the things we maybe want to think about today in terms of the relationship between mental health, psychoanalysis, human rights, and social justice. Thank you.
Hi, everyone, and thanks for this opportunity. My name is Karen Lee Masters. I'm a clinical psychologist based in Cape Town. I'm also part of the Low Fee Clinic of the South African Psychoanalytic Association and Institute. And I'm part of various volunteer organizations such as the Parent Center, offering our services to the various communities in the Cape Town area. Thanks.
Good day, everyone. I just wanted to say thank you very much, honorable members, and to all of our colleagues. My name is Brett Pepper. I'm a clinical psychologist and a psychoanalytic candidate. I'm also the incoming chairperson of the South African Psychoanalytic Confederation. And I have worked in private practice for the last 6 years, but have worked previously in state briefly. So I'm here today in my capacity as the chairperson and to provide support for my colleagues. Thank you.
Thank you. If there are no other questions around our credentialing, then perhaps we'll proceed. I did want to highlight Coralie's presence here and thank her in particular. Some of you might recognize her from her participation and role with the Life Esidimeni hearings. And I'm aware that her volume was a little bit low, though I did really want to lift that, and hopefully we'll get that sorted. I'm going to ask my colleague to start to share screen with the presentation that we have prepared for you. And again, just to contextualize that we are 4 people who are representing a huge community. We have a registration base of about 500 practitioners who are between private practice and work in state. As I said myself, I have been working in state for more than a decade now, and can assure you that 2 things. A lot of our practitioners who are in private would love to be in state, and it's a matter of capacity that limits them to be there. And to that extent, then, the NHI becomes something, in fact, that is very appealing to a lot of our colleagues who are in private. I think the second thing that I wanted to highlight there is while we only have 500 registered practitioners, in reality, we are coming here today representing a huge number of practitioners in public, though also a bigger number who are in private. And I would almost dare to go close to saying the majority of practitioners in private. And I think that this is also then quite exciting by way of introduction, because we are already doing NHI. In this engagement, we are already doing NHI in the work that, for example, currently and Brett and Carly have said that while they are in private, they do a lot of work, which is public sector-based and facing, as well as NGO and supportive of working within the communities. And I think our ripeness for an NHI means that we come here with excitement, actually, and saying thank you for creating an opportunity to engage with us and us with you, and actually hopefully trying to formalize with very technical requirements something that feels like it's already been in the pipelines. Further to our introductory slide, I want to move on then next to spend maybe about 3 minutes or so speaking to you very briefly around why it is that we want to engage and how we hope to engage. And in the next slide, I want to, which is this slide, I want to kind of highlight these 4 points that I've got here. So as I've already said, and I think you can already hear in our tone, we are fully endorsing of a universal healthcare. In fact, we think that it is necessary and it's the best way to go. And we made submissions in 2019, which speak to various things. I wanted to lift these 4 points. These submissions were really also on the back of appreciating the WHO's vision, which really understand that mental health is integral and essential as a component to all health. And indeed, there is no health without mental health. And that is something that I really wish to inscribe in our appreciation of our conversation today. The first of the 4 points that we made in submission in 2019 was the integration of mental health care into general healthcare. And to this extent, I suppose we're speaking about, kind of a medical psychology that really knows that there cannot be the absence of mental health and mental illness in all health, actually. And what we want to do is really try and lift that and make it a lot more understandable and accessible, all the way from the security support staff to the porters, to our nursing staff, to our allied staff, to doctors, and to the management and CEOs, all the way through to you colleagues, also our political leaders, in trying to make it not so foreign and a lot more understandable. We also really appreciated that the value of psychotherapy and interventions in our communities and in our fields goes beyond counseling. It goes beyond one-on-one. It goes beyond on the couch. It goes beyond psychoanalysis with the couch. So actually, what we've seen, especially in COVID, and my colleague Carly Trotter will speak to this a lot more, is how it is so important that we appreciate the mental health and the mental wealth of all of our people in all circumstances, particularly in difficult circumstances. And I think the last year has been a huge challenge for us all, though as a clinical group, what it's given us is an opportunity to highlight the importance actually of looking after ourselves in a mental health capacity, which really becomes essential. It's now no longer divorceable from looking after our overall health. And that included looking after the mental health of patients, though quite importantly, looking also after the mental health of our frontliners and all of the people that are still on the ground today. We also wanted to submit that the relationship between psychoanalysis, which is a particular strand that we are coming from, and the human rights and social justice is also indivisible. And I won't speak to it too much because of time. I'll ask my colleague Coralie Trotter later on, for example, to give case example of how psychoanalysis helped us in understanding what happened in Life as Esidimeni, but also eventually leading to legislative compensations as well. On this point, I also wanted to give you two anecdotes, which if you bear with me with time, I think are quite important. One of them was that I was reminded, in fact, that this is nothing new, the relationship between psychoanalysis and human rights and social justice. And some of you colleagues will know and remember our colleague, Professor Chabani Manganyi, who was South Africa's first Black clinical psychologist and has written a couple of books and memoirs and has contributed greatly to the practice of psychology in South Africa, but also the psycho-justice psychology practice of South Africa in two ways. Number one, being a frontierer as a Black person fighting for psychology and fighting through psychology for patients and people of our community. In fact, he practiced at Barra, which is also where I did a lot of my training. So the second way that he contributed was to the leaders at the time, and he was personally invited actually by Nelson Mandela to sit and advise on different levels and different departments. And he really brought to light that actually not only psychology, though Black psychology, is not just in hospitals, though it's in education, it is in the way that we think of our social justice systems and so on and so forth. So I just wanted to really say the link between psychoanalysis, human rights, and social justice has been there from the very beginning, and I think we should carry on with that. My last point, and I won't spend a lot of time here, is to say that we also appreciate that the provision of mental health care services has to be at multiple levels. In my introduction, I framed myself as working at a tertiary specialist hospital, which is tertiary psychiatric specialist hospital, Tara Hospital, though I cannot do my work with integrity without appreciating and also supporting my colleagues in secondary and primary hospitals and levels. And we do not have the scope today, and I don't know if I actually even need to go into it in trying to elaborate on why that is, besides to say that for me to, with a lot of limited capacity rather, see the patients that I see in the time that I do with the resources that I do, I have to take for granted that my colleagues in secondary and primary are also doing their work there. And I have to support them, in fact, in both a clinical way as well as in teaching and supervision in many ways. So those were our 4 submissions that we made in 2019. And we want to perpetuate these submissions in many ways. So lastly for me to say, and then we're going to move on to a brief video, is that it's a pity that mental health is marginalized. And at the same time, we think that these conversations and these opportunities is trying to address that. We're trying to shift it from the margins into the center, because as I said at the very beginning, really there is no health without mental health. And I think that it is really high time that we start to invest in mental wealth, in fact. So I'm going to ask my colleague Karen Lee to share our video, which really gives you an example that what we're speaking about is not just ivory tower, it's not out there, it's not just words for words' sake. We have in fact been on the ground in communities doing this to give you a sample, colleagues, around what this might look like really in the fabric of our population. We've prepared this video and I hope that it complies. And this is coming from an initiative which we're all involved with. I'm a trustee at this initiative, actually, which is the Ububele Education Trust. And it really works with mothers and children in the community of Alexandra, which is a huge community. And we are based just on the outskirts. So I hope this will speak for itself. And currently, if you go ahead, please, and play the video. Struggling with the sound of it, and hopefully that can also be resolved.
Currently, it doesn't appear to be any sound. I'm not certain if there's a way that you can separately share sound.
My name is Vivian Lambo. I live here in Alexander, and I'm a home visitor at Ububele. We are going to visit Dineo now. Dineo is a young mom. She was expecting twins, but she got one. The doctor thought it was twins because Tebogo was a bridge. I think for me to be there, it also helped her to be like more focused to Tebogo because she was like thinking about the other one who didn't even exist.
The Ububele Home Visitors Project draws on the idea of Umdlezane, a tradition of supporting and protecting new mothers so they can give the best to their vulnerable infants, to give them time and space to find each other through the ordinary challenges of becoming a parent. Vivian offers Dineo an ear to talk through difficulties and share the joy of her new baby, Tebogo.
It is in this two-way relationship between baby and mother that baby learns about the world and learns about love, learns about trust, learns about security. The strength of this relationship built in these beginning weeks and months and then first 2 years provides the best foundation for a child in all other areas of development. Everything about a new baby, everything about a new mommy is geared towards finding each other in this way. But I think we have to be realistic and acknowledge that there are many, many things that come in and interfere. And most of them are things beyond the control of both the mom and of the baby. And Ububele has as our focus trying to support mothers and babies so that they can get back onto that path of finding each other as they were headed towards anyway.
With so many broken attachments through the daily challenges of life in South Africa, if we were to invest in supporting mothers and babies to find each other and cement ordinary, good enough relationships, would we not be providing an antidote to these challenges? Investing in the first 1,000 days is an opportunity to shape lives, to grow little people, and determine futures. The first 1,000 days, an opportunity of a lifetime.
So I'm going to pick up from there, and I just want to mention in terms of the first 1,000 days that in Brazil they had PHC, what they called PHC outreach teams, and they were associated with lowering of infant mortality as well as improved health. So
Can you come closer? Can you come closer to the mic, please?
I know my colleague is struggling a little bit with the with her audio, so I still think that it is yes. Yes, I think we can hear you much better now.
Okay. We tried to fix this problem yesterday. I apologize for it. It did get fixed, and now it seems it's back again. What I was saying is that in Brazil, they had similar outreach teams, and it was associated with lowering of infant mortality and improved child health. So the first point I want to pick up on is that we already, as Zamo said, we already have many things in place that are working. And so the NHI really should supplement what's already working rather than replace things that we've spent years putting in place that we know are of value. And I suppose one could then extend that to medical aids and how they participate, that it's more about how we're going to have a collaborative relationship with each other, as Zamo said, him and I have. So although I'm in private practice and he's in state, I do debriefing of the community groups. There's no charge for that. The Whole of Life Esidimeni was pro bono. And then there's a whole lot of supervision and teaching, which goes on all the time to empower all the clinicians that are working. So I heard this being mentioned before, that, you know, there's an analyst, Winnicott, he said there's no such thing as a baby. And what he meant by that is you can never think of a baby in isolation. And so what we want to propose at that primary level, we're going to show a video a little later again, a short clip, which is also linked to this, is that it is the mothers and the babies, or the caretakers and the baby, that need to be supported. The other thing we want to say is that, you know, I was telling Zamo last night that so many of my patients, when they really feel helped, get very angry with me because they want to know, why is it that what they have learned in their own experience of therapy about the mind, as we are not putting out there for everyone to benefit from. So I think that's a very, very important point, that there are many ways actually of putting the information out in the schools, for example, of having quite sort of systemized programs that teach people, or teach children, about the mind and how the mind works, and the psychoanalytic tenets we use follow all the neuroscience and how the brain grows. So they complement each other. So if, you know, even people who can't afford much have the right to an internal world. We had a colleague from who was trained in Puerto Rico talking to us a little while ago, and she was saying that everyone, no matter how poor, has the right to an internal world. And I think that begins when children go to school, that we can find time to help them understand their minds. And then the other thing, which probably Zamo will pick up on a little bit later, is that unfortunately we have such a terrible legacy and so much intergenerational trauma that we also need to put our nation on the couch. And we need to find ways of talking about how much trouble our nation is in psychologically. So that's the second thing. The third thing I want to pick up on is what Zamo mentioned already, is that my experience of COVID last year, which didn't personally rattle me, was that it prioritized medical health over mental health. And I know this is a new experience for everyone, and people throughout the world were struggling, but this is what we can learn from it in real time. The fact that people's coping defenses were taken away and that people were locked down has been very, very damaging for mental health in South Africa. We can see that in divorce rates, in levels of domestic violence and abuse. We can see it in suicide rates. I, for example, run a referral group, which has just got loads and loads of psychologists on. And we get 5 referrals a day, and most of them are between 15 and 25 with threats of suicide. We actually can't cope. And it is partly because mental health was not taken into account. So in a way, that's such a good portal for us to hold in mind as we go forward with national health, is how can we make sure that mental health is prioritized all the time, because it doesn't matter how well someone is physically. If they're struggling psychologically, they're going to get sick physically, or they're going to get mentally ill. And in COVID, I could also see, we set up lots and lots of debriefing groups, and there were other organizations that did the same thing, that made help available to colleagues. And it was so important with the isolation of lockdown for people to have something that was reliable and ongoing. So I suppose that's what we're also suggesting, that we're like a beehive, where, you know, we don't fight with each other in terms of who's working where. We complement each other, we supplement each other, which is what has happened with today's presentation, and that we envisage something like that for national health insurance. Zamo?
Thanks, Carly. I'm just aware of time, and I'm not too certain how much more I want to say. I think that we've kind of laid quite a good foundation to engage with you, because as I said a little bit earlier, that's most of what we wanted to do. These are, though, some of the initiatives that I think exemplify our first submission, which is that we are ripe and ready to collaborate and to engage in an NHI. Really, we could have done a more congested collage of the different initiatives that are under our umbrella in our private-public partnership of trying to work with a community. So we see the woods for the trees. They're also trying to work with people in the community. So working with individuals, working with the couple of a mother and a child, working with the family and the home visits that we do, working not in silos, not in isolation. They're also working, for example, you'll see there's GRASP and there's some SAPI, working with the practitioners who are doing that work without discrimination. So not working just with clinicians, doctors, though not just working with people who are professionals in this regard, they're capacitating communities and capacitating individuals on the ground. So that's our first submission that this speaks to. I think our second one, very, very briefly again, because I do want to get the video in, is to say that we are also working with the nation. This is not just about helping those who come to see us when they're ill. It's a recognition that our nation, our country needs, in fact, our input. And I want to end here and hand back over to Carly, because I do want you, Carly, to speak around when we are saying that this work that we're doing is also the work that will contribute to policy and to law. We do have case example. And Carly, if you can speak through to the, maybe directly to the Life Esidimeni case that we have, and then we will end with a video, which again gives you a good feel about what it is that we're talking about.
Thanks, Amo. So essentially, Life Esidimeni is not a thing in isolation. We've just written a paper which looks at Life Esidimeni, it looks at the hospitals in the Eastern Cape, it looks at Charlotte burning down, and it looks at the Soweto clinics. And how we understand Life Esidimeni is that, which is written about very sort of clearly in Wachbilong's book, Nation on the Couch, is that because we have such a terrible legacy in terms of lost land, dispossession, persecution, oppression, what's happened is that the intergenerational trauma is resulting in what we call these brick mothers, abandoning its people. It's repeating the traumas. So it looks new, it looks like it's something that's different, but actually it's pulling on what Janssen would call knowledge in our blood. And so how I understood Life Esidimeni was that it was this reiteration of forced removals, of dispossession, of lost land, and that this keeps coming through in terms of our relationships with different clinics and hospitals. So in other words, we can't, this is not about each individual having therapy. This is about a systemic understanding that we're in a nation that is in terrible pain, and that there is a way of not just addressing things at a material level, but also helping our people understand the pain. So an example would be like fees must fall, that it's all very well to lower the fees, but actually they should have had everybody sitting in the concourse at Wits afterwards, trying to understand at another level what fees must fall was about. Now, I know that sounds like an impossible project, but given that we are going to go down the road of universal healthcare, I think there has to be a way of thinking about how do we get this message out in terms of how damaged the psyche is, so that recognition is the beginning of making something different. And just in terms of Life Esidimeni, the thing that was invaluable about that was we took a whole lot of families, 144 people were killed, and we we consulted with those families. So we worked with them for a year to help them recover from the trauma, but through that gathered information. And the reason those constitutional damages were awarded was because the way that we think about the mind and the way that we think about societies means that you can't separate an ethic from mental health. So you can't separate the right to dignity or human rights from mental health. These things coincide, and we've somehow got to get them all linked together in our country. And so eventually that's why the damages were awarded, because we were able to show that because human rights were ignored, it resulted in not only loss of dignity, but terrible damage across an emotional spectrum. The sad thing is that's going on all the time in our country. And if we can try and have, I suppose what I'm appealing for is some part of this that thinks about something a bit deeper in terms of how we are going to get into people's internal spaces and help them think about their minds and help them think about the sort of the national psyche. And that can be through media. I mean, there are various ways of doing that. And so I'm going to hand back to Zamo, and thank you very much again for giving us this time.
I think we have covered quite a bit, and thank you for that, Coralie. And I think that we should go to the video. I already see that their hands raised, so that we can leave enough time for us to have a conversation. So we really do want to end off once again with this sample example of what it is that we want to do and are currently doing. Again, currently we seem to be struggling with the sound at the beginning. If there's anything you can do.
At the clinic begins in the same way every week. Brenda and I carry our mat and a bag of toys and a book to document some of the details. We walk through the clinic, we place our mat on the floor in full view of all the mums and babies and the nurses, and Brenda then goes and interacts with the mummies to explain why we were there and to invite them to come and sit with us.
This is who we are, me and Catherine. This is there. We speak to moms who wants to come and talk to us with anything that they love to present to us with their baby, or just ask any question, about your baby or the difficulty that you have with your baby. And you come to us and you just sit with us and talk.
Her talk has evolved over the years, and in it, she talks about the value of relationships between mommies and babies. And she suggests to mommies that babies are far more sensitive than we've realized, and that the first 2 or 3 years of life are crucial for the future of their development. Brenda then asks from the moms how they communicate with their babies, or what skills a baby at certain ages has to be able to communicate. And she does this in a very interactive style. And mommies will often say, the baby can cry, and Brenda will then say, well, and what about singing, and do you talk to your baby? And there's quite a lot of to and fro in many languages. She then talks about how the things of ordinary life can interfere with what happens between a mom and her child, and how a baby can pick up on some of these difficulties. She then says that we are from Ububele and have as our focus the relationship between moms and babies and strengthening that relationship, and she invites moms to come and sit with us should they choose to. Happy came to the mat with her 2-month-old little boy, and he began telling us a very difficult and sad story about her little boy's arrival in the world. He was born premature and was one of twins. He was born at 7 months gestation, and the 2 little boys were put into neonatal ICU at Edenvale Hospital. She then told us that one of the little boys had died. Brenda and I empathized with her loss, and it felt important to be able to mark the passing of her child, knowing that for a mother, this is a terrible thing to have to deal with. And I didn't want to pass over it very quickly. I felt like it was needed that we name the little boy that she had lost and really acknowledge her feelings. Interestingly, Happy perked up and drew her attention to me at that point. And Brenda and I spoke to her a little bit about what she thought Lindelani's experience of losing his brother was. And she wasn't really able to acknowledge that he felt much. And we challenged that by talking about Lindelani's experience of being in utero with his baby brother, and that towards the end, it must have been quite compacted within her belly. And that in his body, he probably has a sense of him, and that perhaps he is also mourning the loss of someone that he had known since he had any capacity to know. I think this resonated with her because she was able to look to him and make some contact with him. She made some gentle acknowledgements of him and his experience, and she was quite emotional. While we were exploring what support structures were available to Happy, we learned that she had lost her mom to HIV. She had tested this at the same time as her mom and had learned that she was positive as well. Her CD4 count was particularly low, and so she had gone on to treatment. This was a couple of years ago. I was so aware of what Happy had on her plate. She had 2 other children. This was her 3rd pregnancy. She had lost little Lindelgutle. Lindelani, she was anxious about being able to keep alive, questioning whether she had infected him with HIV. In addition to all of the stigma within her family, within her culture about twins and the rituals that needed to be followed, it really felt like this was someone who was in need of, I suppose, speaking with us, and that I wanted to make sure we followed up on. If I think back on that particular baby mat session, it seemed to highlight several important things. One, that Brenda and I are a couple working on the mat.
Great, thank you. I think we'll stop there with our formal presentation, and we'll really we're open now to engagement. And I will invite my colleagues to be available to answer any of your questions. So perhaps I hand back to you, Chair.
Okay, thank you very much for your presentation. It actually was giving us to think very broadly and laterally. I've got 2 hands so far. I would like to, I don't know why, Pepper, you will have to answer questions and raise hand. You'll come in at the time you have exhausted all your time. We then have to give the honorable members time to engage with you. And please let us be back on precisely on the point, because we seem to have finished all the time that we could have allocated to you for more presentation. Now we can go straight to answers. Honorable Wilson, you are number 1. Honorable Munyai, you are number 2. Honorable Kela, you are number 3. Honorable Dr. Jacobs, you are number 4. Any other hand that I have not seen? You can raise it now. In this order, number 5 will be Honorable Harvard. So it's going to be Honorable Wilson, followed by Honorable Munyai. You are number 2 this time. Honorable Kela, you are number 3. Honorable Dr. Jacobs, you are number 4. Honorable Dr. Harvard, you are number 5. Let's start one after the other. Thank you.
Thank you, Chairperson, and thank you so much for your presentation. Quite emotive, and also very, very, I want to say inspiring, but also quite concerning. And I think having just had a presentation by childcare advocates from various levels, this actually goes hand in hand, you have just seen. Health of mother and children is absolutely essential and a key necessity, particularly when we talk about primary health care. And we believe, and you will support us in this, that a sick nation is indeed an unproductive nation. Now, apart from, and when I say mother and children, I think we must also include adolescents here, because, well, apart from the fact that a lot of our adolescents are also mothers today, we must include them as part of the children aspect, because they are still reliant on care from somebody else. And I think apart from the life testimony and the abhorrent past that we share in this country with regards to apartheid, that has had a severe mental impact on us as a nation across the board. I think what we're also seeing today is the exposure of children to crime, death, abuse, drugs, gangsterism, destruction. And my concern always is that a sick child is harmed for life. And so much of this becomes intergenerational. We often think of children in terms of intergenerational sickness as being stunted today, as stunted for life, stunted children. Stunted parents produce stunted children. But I think mental health is equally intergenerational. And I think this was pointed out in your presentation, that harms from the past have affected the mental health of people today and could possibly go on to doing this for generations to come. So in terms of that, and of course we have children exposed to sick and distressed parents. So one thing is leading to another, but and while your presentations were inspiration, and you have 100% support definitely from me, and I'm pretty sure from the rest of the committee, because I think what you do is absolutely phenomenal, particularly in light of the abuses that we are seeing in this country today. What you haven't made clear, and perhaps you can highlight this for me, is your support of the NHI and exactly where you feel it is missing key concepts with regards to mental health. I think this is a critically important issue. And I think the mental health and the intergenerational outcomes of good mental health today are going to be critical. Where do you feel you have been missed out? And do we need to add more to the NHI bill to ensure that this very, very important aspect is covered? Thank you, Chair.
Thank you. I'm not certain if we're going to take all of the questions before we respond, or if we can respond now to that.
I've called all the members one after the other, Mbele. They will get questions. You note the questions, and they will come after.
Thank you.
Yeah. The first question, Honorable Chair, is to ask, how is it possible to realize this aim of the NHI when nearly half of the health spending serves only 16% of the population that had private medical scheme coverage? This is the two-tier system. So that's what we're trying to talk about, that most private receive huge money, and that have implication, of course, to other public service. So we need, pretty much in our view, we need to have one system, but I'm sure you will answer the question. Do you support the NHI? Just to be NHI bill, and just to be direct. And I'm sure this question will need the direct answer from the presenters. And I think, don't you think NHI is aimed to resolve challenges that also include life as demanding that you gave as example, and all other problems that we have experienced through the COVID-19 pandemic? Thank you.
Thank you very much, Chair. Let me first welcome the presentation. You have touched something, Mr. Mbele, the issue of life is humane. Unfortunately, it happened where I'm residing, and it was really frustrating to see that thing happening. But also let me welcome the presentation. I think Honorable Mnyai, you have touched the second question that I wanted to ask in terms of you supporting the bill, but I'm covered on that one. But coming to my question, other question that I want to ask Tatumbele, you have indicated in your submission that you want a psychoanalyst to be included in the advisory committee. Do you not regard this team as part of the integrated health team, which will be participating in the discipline specific interventions as and when the needs rises? Do you think that the participation should be described in regulations? That will be my question to the presenters. Thank you very much, Chair.
Thank you, Chairperson. Just to note, to say that we had noted what the members of the Confederation says about many of them working in the private space and would be wanting to work within the public health sector. It is commendable that they would like to do that. I'm sure that it would be fantastic if everyone should be able to work within the public health sector. We do recognize the importance of mental health and the importance of having the number of appropriate professionals to be able to deliver the services. But if they can maybe answer for me how they would ensure that what their suggestion is, how they would ensure that a more equitable distribution of healthcare workers and services available would be achieved when the prices at this point in time and the wages paid in the public health sector is so high and so much higher than in the public sector. And are these not maybe the reasons why it's hard to run the health system, that there is not space for all of them within the public health sector? Thank you, Chair.
Dr. Harvard?
Yes, Chair. I think my question is for another group presentator, not for Mubele, but I can ask this one. It's just here. Number one, please make a proposal of how you would like accreditation to be revised to address the equity issue you raised in your submission. Number two, how do you propose the state should raise funding for potential flood of undocumented immigrants, which may want to access maternity and child health services in South Africa?
Are you done? Are you done, Dr. Harvard?
Yes, I'm done. I don't think it's for this group. Yes.
Yeah. Okay. Let me just check. I've got two from my side. The mental health is covered on the preamble of the bill, particularly Section 5.4. That lists Mental Health Act of 2002. Now, we just wanted to check if you are not probably comfortable with that, or you would want something more added on that. Number two, did you maybe, you do, I would suppose it is logically professional, you do have a permission to share the videos that you have shared with us, because now they are part of a parliamentary presentation that you made. So we just wanted to be sure that you do have that permission, and therefore those can be kept in our archives. Unfortunately, you do not have much time. We need to be wrapping up by 25 to 12. We are compressed by that. There's another presentation that is coming after you, and at 2 o'clock we must log into the National Assembly sitting in the House, and all committees should have wrapped up latest by 5 to 12, by 5 to 2. So, honorable members, I'm so sorry that you'll have to just get up at any given time to go and grab yourself a coffee, a sandwich, or whatever. We will not have a formal break before. And number 3, there will not be any follow-up questions to Mr. Mpele for now. If your time also, you check, Mr. Zamo, it finishes at 25 to 1. Thanks.
Thank you, Chair. I will then proceed immediately to trying to answer many of the questions, and I will cover myself by saying that a lot of the other questions that have been asked by your colleagues and other honorable members, thank you for those. I won't have the scope to answer them in detail for today. The videos that we have shared are currently in the public domain, and so they are allowed to be shared. However, even in getting there were high ethical requirements that we met. So yes, we share them with ethical right. We would like to participate more. Is the short answer that I want to give. We would like to. We appreciate the position of the preamble, and we want to engage more. We are excited, and though we also think that we have a lot to offer. And to be taught even by yourselves. To be part of what is perhaps what we would need to iron out, perhaps beyond working groups is something that we would need to discuss and negotiate, though we would like to, in fact, let me just put it simply, I am still of the Tuma Mina rhetoric, and we are putting up our hands and saying that we want to engage more. Very, very much, including with the details around mother and child, foreign nationals and non-nationals, not just in working with them, but also working with the plight of immigration and migration, which is so central to South Africa's history. To that extent, I also want to briefly say, because I wanted to be clear that our offerings are not just to patients and people that we work with, though it is to policy and politics that I think currently my colleague was saying, because we are able to work with you as a committee, not just on matters of NHI, though in terms of policy and regulation, though also thinking about our nation overall and where it is. We must be clear that there is no health without mental health, and there is also no adequate mental health that is equitable without an NHI. And to that extent, our mandate absolutely supports the NHI and wants participation in that regard. However, there is also no true NHI without a very strong and fundamental appreciation of mental health and mental illness, and its pervasive, ubiquitous, it is everywhere. And so we do see ourselves in support, and at the same time, the only concern that we have would be the insufficient foundation of appreciating mental health in how we're going to proceed forward. Coralie, I don't know if you want to come in there.
Yeah, I see we've got only a few minutes. Just in terms of question 1, what needs to be added to the bill? The problem with the bill at the moment is that mental health is integrated into general health.
We are struggling to hear that voice. We are struggling. Has that communication not improved as yet?
Sorry, can you hear me now?
Yes, okay, much better,
Okay.
yeah.
So in terms of the first question, the problem is that because mental health has been integrated into general health, it can be left aside, which is typically what happens what happened with COVID. So that mental health, because it is so important, needs to be separated out in some way so that it's not left out in terms of funding, but also in terms of importance. So for example, in section 57.4, there's no mention of psychiatrist, psychologist, clinician. It's small things like that that reveal the gap in the bill, and that once it's then law, become very difficult to deal with. The second question, in terms of do we support the bill, Or do we support a two-tier system? I think there's a difference between universal healthcare, which we said on our first slide, we absolutely 100% support. And that doesn't mean it has to be a single funding system or that it can't be supplementary tiers, that we can't work collaboratively with each other. And I think that there was another question linked to that in terms of resources. We don't have enough resources. We have faced this in the country for years, and we face it particularly in mental health. But that's what we've got to iron out now. So the dilemma is that if we get rid of what is working, we are not going to be able to replace it entirely with a whole new building. So how can we use what's working and then go to all the places we do have and put things in place that are able to work? And then in terms of the question about, isn't this that we are already being included? The thing that I think we're trying to offer above everything else is that we have a particular way of thinking about the mind that can be of benefit. So we don't always act rationally. So the NHI won't simply sort out all the problems like life epidemia in terms of the one question. So what we're suggesting is that there are people involved who are thinking about how the thinkers are thinking, because that's how powerful the political unconscious is. And until we start doing that, until we start thinking about how thinkers think, which is our job, that's our expertise, we're going to keep repeating the mistakes. So that's what I would say. Thank you again. Sorry about my sound.
Thank you, Carly. I actually think that we did very well with your sound there towards the end. And thank you for addressing members' questions quite directly. We have 1.5 minutes. I'm not too certain, Chair, how best to use it, though I will defer to you.
Yeah, you will be making your closing remarks in that 1.5 minutes, but part of that I will also be. I think we are fortunate as a Portfolio Committee of Health, listening to a variety of presentations. Colleagues will come in and say, we are pharmacists, we don't see our names in the bill. We are obstetricians, we don't see our name in the bill. We are psychologists, we don't see our name in the bill. Now, all of that is part of the healthcare. So one would probably have to sit back and say, how long is this piece of string? I mean, who must be mentioned by name? Who must be put under one umbrella as healthcare professionals? But I want to actually challenge you. In the whole world, mental health is not being taken seriously, not just in South Africa, all over the world. There must be a way of health activists like yourselves who are going to be agitating for that. When there's a cut in the budget of health, which happens most often, the one that gets suffered the most within that health sector is mental health. So we should also be talking about that outside this meeting, just as health activists, to say we cannot be left behind, nothing without us as those who have that interest. So your closing comments, I just want preluding to you to say, if you're a pharmacist, I hope you are going to say the bill does not talk to you, does not talk about pharmacists. Now it is not talking about you. So that is a long string that we have of healthcare professionals who are having this and that, but supporting, say, I didn't see my name. Okay, Mr. Mpele, your closing remark, half a minute.
Thank you so much, because I want to recruit your words. It sounds to me, in fact, that you have provided us with the first half of my closing remarks, which is to say that where there is a world where mental health is suffering the most, we can change that and we can lead the change, as we have done so well in many different ways in South Africa, and in fact, invest even more, invest in a radical way in the mental health of our people, especially when our people for many years were discarded as not having an internal world that needed to be educated or looked after or taken care of. And in fact, now we are at a precipice of a different revolution that says that the mental world of our people, all of our people, is not just when they come to clinics or hospitals. It is when we are dealing with them in schools, when we are dealing with them in homes, in their working lives, and in these parliamentary settings as well. So if we decolonize mental health, we will see that it is everywhere. And we are hoping that collaboratively, we can learn how to see it everywhere. And we will begin with these conversations in this committee and through the NHI, which we are very excited about, though we will then soon enough be able to export the idea that it is everywhere to the rest of the world as a proud export of South Africa. So I end there. I thank you all. I thank my colleagues who have joined, and I thank you for your patience. And I really want to recognize that we are four, though we were really supported by very many other colleagues who couldn't be with us today, though with us in spirit and so on and so forth. And I want to thank them too.
Honorable Chair.
No, we stop it at this level, Honorable Munya. We thank you, Babu Mpele and your team, and we will meet some other places and some other time. Thanks.
Great. Thank you so
we
much.
will not continue, Honorable. Yes, thanks.
Thank you.
While they are exiting the platform, let me recognize the presence of Dr. Mzukwa and Dr. Kutsie, who are in the leadership of SAMA, and we will then be taking their presentation. You have 45 minutes to present or less. We would not go beyond 5 to 2 because these honorable members must log into another meeting of the National Assembly where we are all expected to be finished with our committees and move into that meeting. We will then start with you, Dr. Kutsie, Dr. Mzukwa. I don't know who else has joined you. You will indicate and introduce them. Thanks.
Thank you so much, Dr. Ndlomo. SAMA would like to thank the Parliament and the NHI committee for allowing us to present to you today. And we hope that we would make clear recommendations for today. I am very pleased to say that I am joined by Dr. Mzukwa, my vice chair, as well as members of the management, Shirley McGee, our 2 acting GMs that will also be part of this group. I would just like, while Dr. Mzukwa just address and say welcome as well, I would like to ask whether I can, in the meantime, share the screen. Because I'm not very good and I've got my assistant next to me to help and assist me with this. Can I share in the meantime while Dr. Mzukwa takes the floor?
Can our staff assist there? They will do so while Dr. Mzukwa is introducing himself.
To your chair and the honorable member. Thank you so much for giving us this opportunity to make a presentation to this August House. We hope that we will have a wonderful moment where we're going to be presenting our vision or NHI is concerned. Thank you so much, and I'll hand over back to do the presentation. I'll come back later. Thank you, Chair.
Thank you so much. Please bear with me if I struggle, but I think I'm in. Again, just a very brief background for those who doesn't know who SAMA is. It's a professional association for medical doctors, membership of more than 12,000 public and private sectors, members in 9 provinces, 20 branches across the country, and we are being the custodians of a growing advocacy platform that will unite, guide and support members for the health of the nation. SAMA has been commented and participated in a lot since 2011 on the NHI policy and the legislative developments since the first day, as I've said, since 2011. And we have submitted in response to policy papers, draft regulations many, many times, and quite substantially. But we noticed that many of the comments have not been taken up by the Department of Health in the past. If we look at the challenges of the health system that we currently are experiencing, There's a public and private sector. We know not one of them are an excellent example of the best service. Both have got their problems. We acknowledge again the many challenges that have been highlighted in both the public and private healthcare systems over the past 2 years, since such initiatives as the Health Market Inquiry and the Lancet Quality Commission Presidential Summit and the Compact. We definitely need some extreme changes in the healthcare sectors currently. SAMA is engaging in all of the ongoing projects amidst of or aimed at addressing the widespread challenges. But we remain concerned that the NHI seems to be seen as a silver bullet for fixing all of the problems, which it is not, unfortunately. It's important to understand that the NHI is a funding mechanism that needs to support all the other challenges that the health sector faces. NHI cannot achieve the necessary changes which are needed in the health system to make it successful. It's important to understand this. If we look again at the draft, this slide is only a reminder of the purpose of the bill, the draft of the bill, as stated in the 2019 bill itself. The bill aims, and I think it's important, to establish a fund and its powers, as well as a framework for strategic purchasing. That's why we highlight it in red. It's a fund to provide framework. And it's, again, important to understand this going forward. If we look at what is our position on the NHI, so we are in support of the concept of universal health coverage. The proposals in the NHI bill constitute the most significant changes in the funding of the health system that we have seen since 1994. We, however, support a stepwise, resource-informed and evidence-based approach to the implementation of any major reforms in the health system. Many of the proposed changes in the bill have yet to be fully researched for their effectiveness and potential to actually improve service delivery by ensuring that there are sufficient funds and the desired framework to achieve this. Very important, there is a deep-seated lack of faith amongst our membership in the ability of the government structures to provide the financial support structures for quality services. SAMA, therefore, cannot support the NHI as currently constructed. If we look at the concerns with the bill that we have across the since 1912, it is important to notice that the quality of care is not enough emphasis in the bill. There's too much emphasis on cost. There is not enough coverage for, or not enough saying in the bill, and we have heard this morning by other speakers as well, for asylum seekers and illegal foreigners. There's a non-independence of the NHI fund, the monopolistic purchaser, the board and advisory committees not independent and appointed by the minister, the NHI pilot programs that had demonstrated little useful outcomes. Then again, the uncertainty in many of the key proposals where detail is lacking, reimbursement, doctors deliver quality care is a huge problem at the lowest possible price, contracting issues, it's complex. We would propose that it needs trials or piloting before they are included in an act of law. The absence of any structures to address out-of-hospital specialist care, the certification, accreditation, and contracting of health service providers. I will go in a bit more detail in the rest of the presentation on some of these topics that we have now concerns with. So concerns about corruption in responses to our 2019 survey, it indicated a deep-seated lack of faith in the intentions behind the NHI bill, as well as the ability of the Department of Health to run such a scheme. The sentiment was duplicated by both our public and our private sector members. And another survey also conducted in relation to overtime in the public sector revealed significant disillusionment amongst our doctors serving in the public sector, where the sense was that the health system suffers from significant shortcomings in leadership and governance. Similar findings were echoed in the Lancet Quality of Care Commission, conducted as more or less at the same time. There were several practitioners who indicated few issues with the NHI proposals, except that they do not trust the public sector structures to seek NHI. So while SAMA endorses the corruption fighting unit envisaged for the fund, this will still be within the structures of the fund and will not be in a position to confront corruption within the fund itself. So if you look at the quality of details, the details that are missing, the quality health service is an important deliverable of an adequately funded health system. Yet there is no definition of quality, whether it's outcomes-based versus infrastructure versus processes, as yet to strive for. SAMA has made extensive submissions on quality, specifically referring to the Donabedian framework that you see in front of you there. While you can see that the Office of Health Standards may be on its way to evaluating the structures in healthcare provision, making sure that facilities comply with norms and standards, if the process in the middle fall over, as happens in many instances in South Africa healthcare delivery, we cannot achieve desired health outcomes. If we look at the coverage of the population, and again, this has been extensively spoke to during some of the previous presentations. So we see that the Section 4 of the bill limits population coverage to South African citizens, permanent residents, refugees, inmates, and certain categories of foreigners, again, as yet to be determined. Asylum seekers and illegal foreigners are only entitled to medical, emergency services, and services for notifiable medical conditions. The wording in the bill is not clear. Section 4.1 states that the fund will pay for health services for those health services that defines the citizenry, our citizens. But then Section 4.2 addresses services that asylum seekers and illegal foreigners are entitled to. It is not completely clear that these services will be funded by NHI. This could be a phrasing problem, but the mechanisms for this funding need to be cleared up too. This is particularly important if the NHI is to become the only funder of the health services, as envisioned, with claims coming to the fund. Practitioners and facilities will need to claim for these services from the fund too. And this arrangement will probably present a significant challenge for medical practitioners. And if we look at, this is a SAMA organogram, how we see the high-level organogram, and this is a brief overview addressing some of the concerns we have about the powers of the minister as they pertain to the fund and the potential for political interference. The board of the trust is accountable to the Minister of Health, who also appoints the board after a public nominations process. And this has the power to fire a member of a board and to dissolve the board altogether. The board then interviews and makes recommendations for the CEO, but the appointment is actually done by the Minister and Cabinet. Although the board may establish its own committees, it is actually the Minister who establishes the important committees: benefit advisory, pricing, and stakeholder committees. We consider that the Minister of Health has too many powers under these structures. Some also believe that more attention should be paid in the bill to specific separation of the funding mechanisms and the service provision mechanisms, the purchase provider split. However, the process of selection of members of these committees has not been made clear in the new bill, and we believe this opens itself to manipulation. For example, in the appointment of the board of the NHI, clause 13.3 stated that an ad hoc advisory panel appointed by the minister must conduct public interviews of shortlisted candidates and forward their recommendations to the minister for approval. So there are no transparent processes for the selection of such an ad hoc committee, nor any requirements for how they will be selected. Yet they will be responsible for appointing the highest structures within the NHI. SAMA also noticed that the NHI fund will now become a Section 3A entity in terms of the Public Finance and Management Act. In terms of the 2019 bill, all top-level decision-making functions are effectively appointed and report to the Minister of Health. This includes the Board of Directors and the CEO of the fund, as well as the various ministerial committees which will be set up to regulate prices, benefits, and other matters. SAMA, however, recognize that ministerial control over these sorts of structures is not unusual, especially in international contexts. Countries such as Thailand and the United Kingdom, which arguably have successful universal coverage systems, have these entrenched in laws that also provide their ministers or secretaries of health with similar powers. As in Section 2, comments from our membership have quoted mistrust in the Department of Health and its senior staff and functions as reasons of major concern relating to the envisaged powers afforded to the Minister of Health by these structures in the bill, as well as the centralization of the flow of funds through the National Health Insurance Fund. Some of this strongly recommends that the bill should not afford too much discretionary powers to the Minister of Health in operational issues of the National Health Insurance Fund. We also recommend the establishment of an oversight function beyond the Auditor General to monitor the activities and finances of the fund. If we look again at the purchase provider split, why we think it's important is that the split between the purchase and provider is extremely important in this case. As the minister is responsible for service delivery, he cannot also be responsible to be the purchaser. These two entities have to hold each other accountable for their roles, while also working together to provide the best affordable quality of care. This split caused significant challenges between the fund and the Minister of Primary Healthcare in Thailand. However, there is agreement that these challenges were positive for the effectiveness and efficacy and efficiency of this fund. So if we look at the implementation, it's also difficult for us. It's difficult to engage with, support, or object to issues which are not available yet as yet in detail. We look at the payment mechanisms are yet to be decided, as are accreditation mechanisms for providers. Those will at least be determined in regulations of the bill, which will be up for comment and inputs before they are enacted. But, and this is a big but, other issues are going to be determined by directives issued by the fund and not for any comments. And we have seen this now, how it plays out under COVID-19. So these also include key issues like the appropriate and timeless payment of healthcare service providers. If directives are issued, then SAMA feels strongly this must be only after consultation with the relevant stakeholders affected, and only when after consensus has been reached. If we then look at the regulations enabled by the bill, again, the details of how this all will work operationally will still be detailed in the regulations. Again, many regulations, all of which have effectively been enabled by the bill. SAMA will certainly concern itself with these issues, but we cannot support or object to these currently as the proposals are still unknown. If we look at the purchasing of services, under Section 33, it's also a huge problem here. So building the specific funding mechanisms into the bill, and then later the Act will follow, will become extremely limiting. There will be little allowance for innovations in service delivery arrangements and funding arrangements beyond the Act. This will take many years to amend if we find better ways of doing things. Contracting units for primary care have remained essentially the same as in the 2018 paper. For some reason, the specifics of contracting with private primary providers have not been removed. And the bill now states that CAPS will be the preferred organizational unit for contracting, implying perhaps it will not be the only unit which the NHI can contract with. This would make sense given a sub-district may not be able to organize itself into a CAP. SAMA remains concerned about the CAPs and the district health managements, as these run the risk of generating a massive bureaucratic structure. The proposed contracting of units for primary health care, or the CAP, as described as the preferred unit for contracting with the district health management officers, again, as yet to be established. However, these remain nebulous, and the capitated arrangements have yet to be discussed for a CAP. While we are aware that National Treasury has consulting capitation models for general practitioner services, it must be recognized that it's not only general practitioners who would be involved in primary care setting, which by definition offers a mix of preventative, curative, and rehabilitative services, including palliative care. It is not clear at what point this capitation on contracting capitation will operate. In order for capitation to service the purpose, or to serve the purpose of effectively ensuring that practitioners carry the risk of their actions, it must be an all-encompassing fee sufficient that practitioners can manage patients with multiple health issues at the primary care level. Additionally, the envisioned construct of the CAPs holds a contradiction in that parties which constitute a CAP will be healthcare practitioners, yet the CAP has the duty to identify, accredit, and monitor provider contracts. It is not clear where accountability will be situated and where the outcomes and practices will be monitored. So if we then look at, again, Section 35, purchasing of services on hospitals and emergency care also have problems here we need to raise. The fund will pay all hospitals directly. So they will be no longer subjected to provincial budgets. So this is not clear what it would mean for doctors. Currently, they are employed in the public sector, so will presumably be paid by the diagnostic related groups funding. However, private hospitals are not permitted to employ doctors. This results in dual loyalty issues, and the HPCSA has stood quite strongly against this issue. In addition, doctors are generally, and this is important, not happy to be employed by profit-making entities, private hospital groups in particular. So there is no room for purchasing of services here for out-of-hospital specialist services in these structures. The assumption is that this will be delivered in hospital. There now appear to be no clear mechanism for how hospital-based global budgets and diagnostic-related groups will be determined. No specific mechanism available for the determination of case-based fees either. It also seems that all the inefficiencies of the current system in the public hospital and private will be pulled through into the new system too. For instance, you might only see specialists in a hospital environment. This is not necessary nor appropriate. And I think we need to look at this. This is also a problem we need to highlight: certification, accreditation, and contracting. So given the assessments of the public facilities by the Office of Health Standards in recent years, there are likely to be many facilities which do not meet the criteria set even for this first step of quality certification. There are still 3 processes necessary for practitioners to be able to serve users and be reimbursed by the fund. The Office of Health Standards compliance will first have to pass an inspection as been described here in terms of norms and standards, and that is called the quality certification. In 2016, the Office of Health Standards circulated norms and standards for GPs and primary care practitioners, which were very bureaucratically demanding. SAMA did comment, and we are still awaiting draft regulations or further indications as to where this will go. Accreditation will be done by the fund on the basis of whether a practitioner or a facility is suitably set up to meet the needs of the users. Again, appropriate mix of providers seems to lend itself to multidisciplinary practices, and also that their practices adhere to the NHI guidelines, protocols, and formularies, and submit the information regularly as required by the fund. The fund must then enter into legally binding contracts with service providers that satisfy the accreditation requirements. Care levels at primary care, emergency care, and hospital care. And these contracts are to contain a clear statement of the performance required from the providers. The volume and the quality of services needs to be provided. So SAMA is concerned about these arrangements, as the fund is given significant powers to accredit facilities or not. The criteria for accreditation are more vague than those for the quality accreditation. SAMA is concerned about these criteria because the requirements are not laid out. Needs of users not identified. What does this mean? Appropriate mix, will this be determined by the fund? Should it not be determined locally based on the health of the community involved? And if we look then at healthcare benefits, again, while it's difficult to comment on the benefits which have not been determined yet, there are some apparent challenges here too. There's no space for ambulatory out-of-hospital specialist care, including mental health and services such as ophthalmology, dermatology, gastroenterology, etc., which are either provided out of hospital or in innovative methods, like day clinics, in-room, or in the private at the private sector level. Many sectors and services which are supposed to be available to patients under the current system simply are not available at the point of care. An example being essential medicines. As a result, the promise of a determined benefit means little to clinicians. If medical schemes are to cover only what is not covered already, then these NHI benefits will need to be made clear without a shadow of doubt. So the role of medical schemes, is, it would be unconstitutional to remove any person's right to seek healthcare through some other mechanisms if it is effectively not available through the NHI. If you take hypertension and diabetes as an example, that might be covered. It might be covered, but only through a very narrow formulary. So patients who do not respond to the essential medicines options must have the option to access care over and above the NHI protocols if they can. And we see this on a daily basis at primary healthcare levels run by the public sector. So to sum up again, SAMA specific recommendations. If we look at it, population coverage, there is the clauses, these are the challenges that we have with the current formulations, and this is what our proposed amendment is. On the population coverage, they need to clarify this clause and its meaning, as these services are merely available, or will they be covered by the National Health Insurance Fund? And under clause 4.3, the definition is to be included. Registrations as users for clause 5.8. Patients should be able to present at any healthcare facility provided they are registered at a health facility. This will provide difficult for specific capitation structures proposed later in the bill, which is why we propose these are removed from the bill itself. We know that patients are traveling, they move around, they're not staying in one place. If we look at the rights of users, that's paragraph 6.1. Access to care is very time dependent. For instance, cancer patients are very negatively affected by long waiting periods. Healthcare services coverage, clause 7.1e. Out of hospital services are completely neglected in the bill. There are multiple innovative ways for these services could be delivered and funded. And on 7.4, proper process for non-funding to be developed and the bill to refer to the structure which makes this decision. Then we nearly finished with this clauses. So purchasing of healthcare services on clause 35. We want to remove these specific mechanisms to make room for evidence-based, piloted, and proven successful delivery structures. These could be innovative arrangements which have not been explored as yet. Private funding. SAMA believes it would be unconstitutional to prevent patients accessing health services they need, which are supposed to be available through NHI, but are not because of resource constraints. Patients should still have a right to access these services through other funding mechanisms. So SAMA did a survey in November 2019 under our members. And if we just briefly touch on this, if we look at the survey, if you look at the age and gender, you will see it was 988 doctors participate. SAMA does have slightly more males than females, and our members are over the age of 40. So we are satisfied with the representation that we have here. So if we look at the sector and provinces, we also have a nice spread of respondents from private and public sector, as well as the representative response of members from the different provinces. The majority of our members are in Gauteng, Western Cape, and KwaZulu-Natal. So the questions that we asked them on NHI was the following. We asked them about national health insurance proposals will improve the quality of care in the country. 78% of members strongly disagreed that NHI proposals would improve quality of healthcare in South Africa. Quality of care emerged as a significant concern for public and private sector practitioners. If we look at the other question is, I am concerned about NHI proposals for the following reasons. You can see again, it's all about quality, but the biggest concerns were governance and potential for corruption under our members. If we look from the NHI proposals, it is clear to me how I will be remunerated in the future. You will see again, for the doctors, their future remuneration is uncertain, and the NHI proposals have done little to clarify how funding mechanisms will unfold in the future. This concerns come from both our public and private sector doctors. 80% of doctors are very uncertain about their remuneration in future. If we just look at what position should SAMA take in relation to the current NHI bill, and you will see the majority of our members do not completely oppose the bill or NHI. However, there is agreement that much work needs to be done on previous reports like the Health Market Inquiry and the Presidential Compact before we introduce the bill as it is. Then, second last slide, are you considering immigrating because of NHI? So SAMA really debated about even asking this question in our survey, but eventually we decided that we had to. We have to start to understand the kind of perceived threat which the proposed changes pose, real or imagined, and how our doctors are reacting to it. So lots of doctors is also a potential loss of membership for SAMA. So if you lost the doctors, we also lost our membership. The split was relatively even, with 38 stating that they are considering immigrating because of NHI and 6% for other reasons. 39% are not considering immigration. If we then look at the thematic analysis of this tax, you will see the survey also collected hundreds of free test comments. Main themes is doubt about the national government's capability to run the system. National health insurers not address the failings in the infrastructure, extremely open to corruption. And then the main proposals was fix the public sector to a point where it can begin to appeal to private sector patients, engage with private practice to provide additional services funded by the state, pilot the proposed systems and payment mechanisms before you introduce them. In conclusion, SAMA is committed to the cause of universal health coverage in South Africa. We have actively engaged in discussions and projects for the improvement of the conditions for patients in both the public and private sector, quality initiatives, policy discussions, and advocated where crises have manifested in service delivery to the country. We are committed to serving the patients of this country and improving the levels of quality of care patients receive. Many of the proposed reforms, new structures, and challenges in governance and accountability have not been tested or explained in a policy document. We therefore cannot support an NHI bill in its entirety, nor the multiple structural and functional reforms and new entities, units, and agencies which are proposed. And with these few words, I want to thank you. And we can open up for questions. Dr. Muzukwa will be with me, and all our other members, Ms. Shally McGee and Dr. Oosthuizen, as well as Mr. Richard Tambai will also be available for asking the questions. Thank you so much. I'm going to stop sharing.
Okay. Honorable members, I have already got a list of those who would like to ask questions, and I'm going to read their names because they were also active on our group. Tata Kutsie and the team that is with you, interesting. It would have been nice if you had added one more question on your questionnaire on those questions, on those colleagues who say if they were to be an NHI, they will migrate, to ask where they will go to in the world, because the World Health Organization is advocating for universal health coverage. Now, you have to actually select very few countries that are not following this route worldwide. So I would have loved to have seen you asking them that question, where in the world will the colleagues be going to? Honorable members, these are the colleagues who have requested to make their contribution in this order. The first one is Honorable Sokacha. Number 2 is Honorable Wahube. Number 3, Honorable Dr. Tembekwayo. Number 4 is Honorable Wilson. Number 5 is Honorable Dr. Jacobs. And now I see on the platform here, Honorable Kela, number 6. Okay, there's another hand, number 7, Honorable Munyai. That order, please. Please remember your number and follow one after the other. I will really cut short at 5:22 because we have to move into the National Assembly formal sitting. So all the questions and responses must take place between now and 5:22. Thank you. Start, Honorable Sokacha.
Thank you very much, Honorable Chairperson. Chairperson, let me welcome the presentation from SAMA. Just one question from my side, Chair. On coverage of asylum seekers and undocumented migrants, how does SAMA propose that additional funding for these groups in the population be mobilized in an environment of financial resources constraints, even for bona fide South African citizens? Thank you, Chair.
Thank you, Chairperson. Thank you to the presenters. And I think that we got some valuable technical inputs from them regarding some of the concerns around the bill in itself. And I think we probably have to appreciate that there certainly is a difference between the piece of legislation that we're dealing with now and the concept of universal healthcare. And I think we've got to be careful not to confuse the two either deliberately or not. I do then want to pose this question to the presenters around the governance model, as it's something that I think is one of the greater weaknesses of the legislation that we as a committee have to work on. And so I'm always interested from some of the presenters to perhaps give input on their side to help us as a committee when we have to go clause by clause in this bill, essentially, panel beating it, that some of the governance concerns, particularly around the appointment of the board that manages the fund. And of course, there's various models around the world on how some of these things are done around state-owned enterprises. How are boards appointed? How is this public fund managed by whom? So I would like to understand from SAMA, as people who are obviously very active players in the health sector, what their view is in terms of being able to build in good governance models in a way that could get us closer to universal healthcare. Because I think all of us can be in agreement and in IDEM that universal healthcare is something that we need to work towards. So what can we possibly do based on some of the proposals in the bill and those that are not even in the bill to build good governance models to get us closer to this ideal in their view? Thanks, Chair.
Thank you, Chairperson. To the SAMA, I just would like to say we respect your approach, your explicit point of view on your presentation. But you mentioned that the minister has got too many powers. I would like to know, according to you, how would you, who is supposed to be included or share the powers that are given to the minister, to say what are the other powers that can obviously be transferred to the other executive members. And then the second question is based on the recommendation that the proposed payment mechanisms should be adequately piloted before they are included in the Act. But my question is, what would be an appropriate representative sample and its geographical spread, according to you, that would possibly yield an approved, valid, and reliable results, that would say to us that definitely they can be included, that the proposed payment mechanisms can be included in the Act. Thank you, Chairperson.
Thank you, Chairperson, and thank you, Soma. I think it was an absolutely superb presentation, and I think it has highlighted some of the issues that we have been raising over the last periods of time. You spent a lot of time on certification and accreditation of facilities who would apply to participate in the NHI program. However, in the last report, only 1% of all facilities and clinics or whatever who were possible contenders for the NHI actually only met the validation and accreditation criteria. I think this is a huge concern, and if you can give us any more information on that, I think that, you know, I think this, if NHI is going to be dependent on the accreditation of facilities, of doctors, of clinics, of anything that's going to apply to service the NHI, I think what you're raising is very, very important. And the fact that only 1% of those facilities currently would get accreditation, I think that is seriously alarming. And then I think predominantly I'm covered by people who've questioned before me. But one of the things I would like to discuss, and perhaps you can give us more on this, Ms. Kunsia, is that, you know, in order for the NHI to become applicable, a lot, and I mean a lot, of other acts that dictate the regulations and establishments of other sections of the health system would have to be changed in order for them to be relevant in the NHI. Perhaps you could give us some of these and the effect that that is going to have. Because one would say essentially all of those acts would need to be changed first before the NHI is implementable, or perhaps you can correct me if I'm wrong. Do we approve the NHI and then go and change the various other acts, and there's a lot of them that need to then be changed quite quickly in order for them to be applicable to the NHI? I hope you get it. I hope I'm making sense of that. The failure of the pilot projects, I think this is quite critical. Those projects all failed in the main. They were just an absolute disaster. And it's hardly surprising then that medical professionals are actually a bit concerned about what has happened, unless you can share more information with that. And I think my major concern, one of my major concerns is that in the last year or 2 or 3, we've seen health going backwards. And I think if we're going to move forward, we can't be going 1 step back and 3 steps, 1 step forward and 3 steps back. And we saw this predominantly in the Northern Cape, where the health systems there have collapsed to such a point because of lack of infrastructure, lack of staffing, lack of budgets, lack of support by the health department, that, you know, even their child mortality rates have gone backwards because they're just inadequately supported, without primary healthcare structures, without oncology services, without the proper infrastructure. And lastly, I just want to talk about the establishment of the committee, which will get to decide on the basket of services that NHI will cover and the costs. And of course, the central procurement of that is quite critical, how that will affect us. I think you've covered this briefly. And I hear what you say about powers to the minister, and I think this is concerning because obviously the monitoring and evaluation of the entire NHI project will fall predominantly under the board, who will do the monitoring and evaluation and the monitoring and oversight of the fund. So I hear your concerns of that, and they are very real. But I thank you for a very, very good presentation. Thank you.
Here's Chairperson. I want to speak about 2 points which were raised. The one is the point on corruption, and the other one is on the surveys, which were alluded to. Now, the question on corruption, I want to ask whether the SAMA does not think that Section 21K speaks enough about prevention of corruption and catching corruption as it happens before it has too much of a bad effect. Meaning that the NHI fund must set up structures to deal with the corruption, such as internal audit and development of risk engines to use data analytics to catch corruption as it happens. And then with regards to the surveys which were done, and I know that the surveys were done with the doctors, and secondly, also with the public. Now, we know there are 40,000 doctors registered on the HPCSA register, and SAMA has 12,000 members. There is mention of 38% of doctors saying they would immigrate because of the NHI bill implementation or the implementation of NHI. So what percentage of that 12,000 participated in the survey? And what is SAMA saying are the views of the doctors that did their poll, when they did their poll, who did not participate in the survey? And then the survey on the patient satisfaction by SAMA does not tally with the stats of MRC and the Stats South Africa survey that shows 84.8% of the public are satisfied with the healthcare currently. So thank you, Chair. I would like some clarity on those questions. Thanks.
Thank you very much, Chairperson. I will go straight to my question to SAMA. My first question, Chair, what does SAMA understand by the term portability of services? The other one, a question that I think others act changed on page 31 of the bill. But also the other question, health is not going back. Evidence that the health has improved given improved management of HZIV. Life expectancy has increased dramatically. I mean, yes, dramatically. So those are my question, Chairperson.
Last one was Honorable Munyai.
Thank you very much, Honorable Chair. What does SAMA say about some of the members that is opposed to their position who support NHI? Because this, as we've seen that in the television several times, when the member says that me as a medical doctor and as a member, SAMA doesn't support me on their position because I support the NHI. But the other key issues that is SAMA, does SAMA support the current status quo of the two-tier systems, which really favor the highly rich and the medical aid funded and so on, while the poor languish, with no solution that's equitable to everybody, and so on. And I think they raised the question that you have raised, Honorable Chair. But just to take it forward, you remember Angelique Kutsia that in 1994, in the advent of democracy, there was also some who claim, based on the research, that they are going to in fear of a democratic, more equal society, non-racialism, and also unity of the South Africans. There was huge survey saying that they want to go overseas and so on, for the fear of the unknown and so on, as I indicated. CEO Angelique Coetzee and the team. Thank you, Chair.
Okay, thank you very much. We may probably not go through all of the answers, but I hope they will do their best. On my side, just to make a follow-up on some of the things that have been raised, starting from what is Honorable Munyai is saying, I was not aware that SAMA will make reference to their survey of the participants who were largely doctors. We are following these things in the country. It had its own noise. Forget about people who are not members of SAMA, but within SAMA itself. Now, I was hoping that we will talk less of it, because there are people who are actively SAMA members and they were really having strong views. Forget about people who are not even there in SAMA. Strong views opposed to that which is now documented and officially presented. But number two, I am not aware whether SAMA does follow the Presidential Health Summit Compact and what it says with regards to things related to corruption forum, some of the prerequisites that must be attained prior to the full implementation of NHI, and some of the sort of the strides of the Office of the Health Standard Compliance. Number three, I think the thinking that comes with this bill on the single payer is actually meant to promote cross-subsidization that will reap efficiency benefits on the monopsy buyer. I wonder what other method will SAMA propose in this regard. Now, the last part, which was also very disturbing to me, Dr. Coetzee was actually not part of the presentation last week, but she would have wanted to have a different presentation that was made by HPCSA. Now, HPCSA is a different program, and as far as I'm concerned, Medical and Dental Board, some of them are members of Dr. Coetzee, are not necessarily making the 11 other boards in the Health Professions Council. Now, it was worrying as to why was Dr. Coetzee having challenges with the presentation that was made to this portfolio committee by another entity, and actually saying it was because Dr. Coetzee has a chance now to make her presentation on behalf of SAMA, not on behalf of HPCSA. Can we get their responses on these issues? Thanks.
Honorable Chair, I just forgot one element, if you allow me. They may even respond in written form in the later on if they can't finish on time. If you allow me.
Yes, put it in, Dr. Honorable.
Yeah. I mean, in elected democracies such as ours, where the party that wins the election would want to implement its manifesto commitment. And I know they were concerned about the powers of the ministers. And I'm saying that the minister have executive power, and they are really really accountable to Parliament. And this is not different from any other institution that Dr. Coetzee would have served within the government of South Africa. Did they see any other interference, political interference in that regard? Because minister is accountable, you have executive power, it's accountable. Because this is a democratic structure of a unitary government, not a federal government. Does the SAMA or Dr. Coetzee have an issue that the minister perform his function as outlined by the Constitution of the Republic? I'm saying that, and when the board, for instance, is established, there's a structure of governance. Yeah, thank you.
Yeah, we have captured it, Honorable Munai. Let's leave it at that. We don't have much time now. Yes.
Thank you. Appreciate the questions. I will tend to answer some of the questions. Dr. Mazukwa will answer some of the questions. Dr. William Oosthuizen will answer, and Ms. Shelley McGee will also answer. I just would like to, on the last few that was asked around the people who want to immigrate to other countries, I think what is extremely important is to understand the reason why they want to immigrate to other countries is because they don't trust the current system. So although they will immigrate to other countries working under another NHI system there, that NHI system is most probably a trusted by that country and being in place for many, many years. And they would most probably feel more comfortable in a trusted environment than going and being part of a pilot. We also cannot comment on people going to Australia and then are unhappy there, but it would be nice if we can have some of those evidence being sent to us so that we can also maybe interrogate it and take it up to our members. Then also we cannot comment on Stats South Africa and MRC. We can, because that was a patient survey, and this is a doctor survey. We can only comment on what our doctors are telling us. And this is what our doctors are telling us. So to come back to your question, around about 988 members participate out of 12,000 members. I need to tell you, in the medical field, this is a high participation. Doctors are known for not being able to participate or the lack of participation in any of these surveys. So this was quite well attended survey, and we do intend to follow up the survey. But this is, as I think Dr. Lomo said, should not be so much about the survey. Why we brought it in is to show that it's all about trust going forward. So SAMA are in support of universal health coverage. We, we don't have any problem because we acknowledge that there should be good universal health coverage. But it's important to understand that the NHI is a funding model. It's not the UHI, universal health coverage model. It's a funding model. So if there is not enough funding under NHI, not enough good frameworks in position, you would be having difficulty in doing a universal health coverage funding. It's also important to understand that equal access does not mean equal care of good quality healthcare. Equal access just means I can now go to a clinic or I can go to a doctor. Whether I get any good evidence-based treatment there, that's another story. So the word equal access for us in the medical field means something different. It just means I've got access to that. Then just want to quickly go through some of the questions here. On the corruption, section 21, we will ask Dr. Oosthuizen to come to that. Again, the stats we cannot. I'm not sure, I couldn't hear properly what the Honourable Anna Aguilar asked, accountability of services. I'm not sure whether that was what she was asking. Yes, we do acknowledge that life expectancies did increase. And it should have increased because, post-apartheid, we are working very hard in all the sectors to make sure that healthcare reaches all the people. So if it didn't increase, it would have been a failure of the current government. So we are very much in agreement that we did. So, and regarding NHI, we had, again, regarding NHI and our members, we had numerous interactions with our members. SAMA didn't just wake up one morning, do a survey, and then said that is the Alpha and Omega. Our doctors has been asked, we have polled, we have done a lot of work in the background regarding get the feeling of our doctors around NHI. If I can just ask Dr. Mazukwa then to answer some of the other questions. Thanks.
Thank you so much, Honorable Chair and the honorable members of the committee. I think my starting point on answering some of these questions is the question of universal health coverage. I think we all agree that we support that broad concept of universal health coverage. South Africa has decided to use the NHI vehicle. As SAMA, the last National Council of SAMA took a stance, a clear stance to support NHI. But we raised several issues that are presented to this committee today. So I wanted to clarify that our last National Council supported NHI, but raised these issues that are presented to the committee today. So those are the first thing that I thought I should clarify to this committee. The second issue is around the issue of asylum seekers. I do believe that it's not a simple question that we can answer now, but what we thought, the discussions that have been going on in the association was whether it's SADC or whichever geographic geopolitical region that is identified could, come up with a way of really funding, asylum seekers or even people from other regions. Because you remember, in South Africa, even now people are coming from other countries to seek healthcare in our country. And what do? Do we chase them away? It's a simple thing like it happens within South Africa, in the provinces within the country, where you find that, for example, you'd find people from the Eastern Cape going to KwaZulu-Natal looking for healthcare, or KwaZulu-Natal going to Gauteng looking for healthcare, and all those things. So it's happening already. But the discussion, we have never had a thorough discussion of how we find this. And I do think that those regions like SADC, they have a huge responsibility of looking into how do we find the asylum seekers. But it is not proper for a clinician, for a doctor, to be chasing away an asylum seeker and said, but you are not covered, we cannot provide healthcare. I don't think any doctor can be able to do that. All we are trained to do is on ethics. We need to attend to the health of a patient that presents before us. So I do think that that's where we stand on those issues. Regarding the issue, I'll answer the issue of the powers to the minister. I would like, first of all, to say, let us separate the position from the person. We are not having any issues with the current minister, Dr. Zweli Mkhize. So we do not want to personify the office of the minister. So it stands there alone. It has to be looked there alone objectively. So what we are saying is that, regarding the appointment of board members and even some committees of the board, because our thinking was that the standard practice is that if you have a board of directors already appointed, you also allow that board then to appoint committees. So if you go even to an extent of appointing some of the strategic committees, so we think that this is a bit of a problem. We have a minister who is now going to interfere with the management of the fund, who is really hands-on in terms of being who's going to be there, dealing with strictly management issues. So I do think that there's a problem there, but also if you have people who are appointed by the minister, so the challenge might be that at times we might have a person, some loyalty. People these days, we know what happens in those areas. You'll find that there's this loyalty, that a person becomes so loyal as to forget even how to, do their fiduciary duties in terms of being a board member and all those things. But I think there are many other issues that we have identified in the presentation that we think, no, it can't be that just the minister. Maybe if it's a cluster of ministers, not just one minister looking at the issue of appointing board members and all those things. I think there's a problem if you personify the office of the minister. Because we know that next time it might not be the current minister, it be somebody else who might do some other things. So that's where our problem is. And maybe let me stop there for now.
Thank you. Can Richard come in? Oh, not Richard, William on the section 21. Thanks.
Certainly. Good afternoon, members. It's William Oosthuizen from SAMA. I'm the legal manager and acting GM. I'd just like to thank the honourable members for their time and for Dr. Coetzee for an excellent presentation, as well as all our SAMA members that have participated and given us their views that have informed this. I'd like to thank some of you for the insightful questions that you did have. I did notice a bit of hostility in the tone of some of the other questions, which is unfortunate, given that we are trying to provide insight to better the system for all of us. I think you would recognize that our members, the doctors out there, just want the best for their patients. And that is what we're trying to do here. Let me speak to the corruption element. So certainly we do support the investigative unit that will be established. Where the concerns are is when you have to investigate corruption from within, that there might not be enough independence. And I don't know whether you've looked at the news recently, but there are numerous examples of sycophants being employed in certain key positions and then corruption taking place. Unfortunately, we've once again seen it in the PPE scandals that have taken place. And there's also this Zondo Commission ongoing, where it seems to be that parliamentary oversight isn't always necessarily enough to combat some of these issues. So it's something that we take very seriously. Every penny stolen from the population and from the health system is a penny that could cost someone their lives. So I don't want this to just be dismissed as people just making noise. This is a serious concern and it needs to be taken seriously. And as Dr. Coetzee has alluded to, there is a severe lack of trust. And that lack of trust didn't just happen overnight. Unfortunately, many of our members have been the victims of corruption and the mismanagement of the systems. And I would hope that the members on this call, the honourable members, take some of these concerns very seriously and start to think of how we can implement systems to ensure that we have a universal healthcare system that provides quality healthcare for all of its citizens. Thanks so much.
Thanks. I'm not sure whether there's still time for Shelley McGee just to come in, Shelley, and then I will ask Dr. Mazukwa to close off. I'm mindful of the time. Thanks.
Yeah, we can only do it in the next 4 minutes, not more than 4 minutes.
Great. Shelley?
Right, thank you. I'll be very brief. So I'm Shelley McGee. I am the health policy researcher at SAMA. I did just want to address the issues raised with regard to the certification and accreditation of facilities and the reference made to the fact that 1% of facilities are meeting the requirements for certification at the moment in terms of the quality standards. So, obviously that is a concern for us, but it's not to say, regardless of what is going on in the bill at the moment and I guess the lack of attention paid to quality of care in the bill, there are other mechanisms. We are involved in Pillar 5 of the Presidential Compact, and that is focused really on the quality of services. So we've been quite involved with structures within the government and supporting the government to sort of drive towards the new, and that was published admittedly after the bill, the National Quality Improvement Plan. So there are mechanisms happening now where they are trying to address the quality measures in facilities and make sure that those are up to scratch. So, we'll be supporting those in the coming days. Then we also got a question about let me just find it here. Yeah, we got a couple of comments about SAMA's patient surveys. We haven't conducted patient surveys, so we certainly are not comparing to the MRC surveys. So I'm sorry if the slides were confusing in any way to the members. We didn't report any patient information. I just need that to be clear. It was all based on our doctor surveys. Oh, and then also the failure of the pilot project that one of the members asked about as well. And I mean, I would have to say there, I don't know, we did manage to get some information out of that, but I think there were a lot of learnings for us in those pilot projects. And that I think the challenge there was not a failure, it was that they were not really designed to achieve anything specific, you know, from the get-go and from the beginning. So, you know, we didn't necessarily, and it was early days, it was sort of back in 2012 when those pilots started. They really did not forge forward with any kind of real outcomes in mind, which resulted in the fact that it was very difficult to measure those outcomes, you know, once we actually came to look at them. So I think, you know, and we've urged in our submission and today for pilots, you know, to go forward before we actually build these mechanisms into the bill. And those need to be, you know, properly designed with an outcome in mind and, you know, some kind of really clear, and I think the MRC in their presentation the other day also highlighted the fact that we need research to be done in these areas. So, and it needs to be, you know, properly designed with a specific outcome in mind and a I guess a hard objective to be achieved with those projects. Otherwise, it's just an ongoing project that achieves very little for us. Thanks.
Honorable Chair of the Portfolio Committee, we would like to thank you and the rest of the committee members, the honorable members, for allowing us to have this opportunity to present our view and also the issues that were raised in the presentations. We hope that we are going to have a smooth relationship into addressing the issues that we are raising. And we really thank you for this opportunity and also to the rest of the team in SAMA. Thank you.
Yeah, Dr. Kutsie, Dr. Mzukwa and the team, please do make use of your continued engagement with the Department of Health and the Minister in particular, because you could also find your way in there. We are listening as a Portfolio Committee, going to do our own report based on what we are hearing, but you also have an easy access to the minister being the leadership of doctors in the country, and therefore your continued engagement, support, leadership in touch with the Department of Health is going to continue, and we need to encourage you to doing that continuously. Thank you very much. Okay.
Thank you.
Okay. Yeah. Honorable members, we need to disengage. We are meeting again at 9 o'clock. There are more presentations. We need to disengage to go to the National Assembly sitting. I'm sorry you do not have much time to have your decent lunch, but I hope you'll be able to try your best under these circumstances. But thank you so much for your participation, engagement, listening, and as you are taking notes on this process. Thank you. Meet you tomorrow at 9 o'clock on the same program. Thank you.
Thank you, Chair.
Thank you, Ma'am Kela.
Malibongwe.
Igama lamadoda.
Igama lamakhosana.
Okay.
Recording stopped.
Umhlobo wakho bani lana phakathi kwami nosokhatsha usokhatsha